We are live now.
Good afternoon, everyone. I am Dr. Adarsh Bansal, PhD scholar at the Department of Community Medicine, School of Public Health, PGI. Alongside me is Anandita Bose, Senior Program Associate, New Delhi. We welcome you in this first ever two-day virtual symposium on ensuring immunization for all in the context of COVID-19. It is being organized by PGI Chandigarh in support from Global Health Strategies, New Delhi, and International Vaccine Access Center, Johns Hopkins Bloomberg School of Public Health, USA. So without wasting any much time, I would like to request Professor Amarjeet Singh, Head of the Department of Community Medicine and School of Public Health, PGI, to deliver the welcome address. Sir is a prominent academician, and his field of interest is women's health and health promotion. He has published over 300 articles, authored 10 books, and co-authored 38 books. He has completed 65 research projects. His innovations include mHealth, Salam Namaste campaign, and upload of patient empowerment material on PGI website. He has also made 8 short films on various health topics. So over to you, sir.
And hello to everybody. I am Dr. Amarjeet Singh. Presently, I am the head of the Department of Community Medicine, School of Public Health, PGI, Chandigarh, India. So I welcome you all in the two-day virtual symposium on ensuring immunization for all in context COVID-19. So as we all are aware, our routine life, our interpersonal relationship, our outings, travel, tourism, everything has been disturbed because of Corona. So it was quite natural also that routine health services will also be affected by this emergency, this pandemic situation. We can say that impact on routine services or routine immunization is a kind of collateral damage because of Corona pandemic. But as we are all aware that we are committed to ensure the welfare of society, in particular the healthy quality of life, the show must go on. And in this context, it is important that the team which Dr. Madhu Gupta has taken the initiative to bring them all together, like Global Health Initiative and the eminent personalities like Dr. Matram Santosham and Dr. T. Jacob John. So this is a good initiative by Dr. Madhu Gupta and her team that they will be discussing the current situation and future kind of strategies to deal with this thing. But my personal view is that it should not get converted into rhetorical things. Just by saying that we should continue with routine immunization, things do not get done. We have to ensure that if we are really serious about that, safe delivery of the routine immunization to all concerned, particularly the vulnerable section of society, infants, under 5s, antenatal women. So this should be ensured that all SOPs are followed without exposing them to further risk, because it is a give and take situation. That if we call them to centers for routine immunization, they may get exposed to Corona. And if we don't, they may have the risk of getting the vaccine preventable disease in future life. So it is something like if we say health education, we can't say that it is a tangible thing. We just advise people, we counsel people. But routine immunization is a thing which is tangible, something physically we are providing to the people to ensure better quality of life. So, but another thing which I feel is that the innovative aspect is missing. Like telemedicine, about a decade back, nobody was talking about it seriously. And now it is the talk of the town. Things are changing. Artificial intelligence based and other things have come up into healthcare delivery. But for routine immunization, somebody should come out with innovative ideas. So how to ensure that? Because it is the question of rebuilding the faith of the people in routine services again in the context of Corona. And ultimately, it is about the people, for the people, and with their full cooperation. So some strategies will have to be discussed. I believe this symposium will be one platform where concrete things will emerge so that people are really benefited. So I give best wishes. From my side, I think this symposium will be a great success. And in the end, I also thank our director, Professor Jagat, who has been a pillar of support for us, and we all derive our strength from him. All the institute, in particularly our department. Pharma. Thank you.
Thank you, sir. I would now like to request Dr. Jagatram, Honorable Director, PGI Chandigarh, to deliver the inaugural address. Dr. Jagatram is a prominent ophthalmologist and academician and recipient of Padma Shri, the fourth highest civilian award in India, and other prestigious awards. He has contributed over 300 publications in reputed indexed national and international medical journals, including the most reputed, the New England Journal of Medicine and the Lancet. He is the author of several books and has written more than 45 book chapters. We are honored to have you here, sir. Over to you.
Dear friends, we are meeting today virtually in the midst of greatest war mankind had ever waged over the past century. COVID-19 has changed the way we look at the healthcare and its overall importance in building a nation. The world today has reported over 140 million COVID-19 cases since the start of pandemic, and over 3 million of them have lost the battle against this deadly disease. India alone has reported over 15 million cases, and just a few days ago, we have crossed grim milestone of over 3 lakhs cases per day. Various factors have been responsible for the recent surge in infection, like lack of COVID appropriate behavior in general population, large religious and political gathering, upspringing of mutant virus variant, including UK variant, and Indian double and triple mutants. Airborne nature of the viral transmission makes catching the infection extremely easy the moment one let his or her guard down. It is easy to get bogged down by these numbers and feel astray. But there is a light at the end of tunnel. That is the vaccine. Scientific community has worked at breakneck speed since the start of the pandemic has started. The result, India gave its first vaccine shot in under 1 year of reporting of the first case. Today, we have 3 vaccines which are approved for use by Government of India and many other in the pipeline for the near future. The Government of India has further widened the net of vaccination by opening up vaccination for all above the age group of 18 years from May 1st, 2021 and exempting foreign-made WHO-approved vaccine from bridging study in India, thus allowing for their expedited approval. This will extremely beneficial in the fight against COVID-19 as this will help in achieving the herd immunity faster, which indirectly help in reducing the spread of infection. Till date, over 135 million doses of the vaccine have been administered in our country in record time, which is a great achievement in itself. Despite this, vaccine hesitancy is still rampant amongst the eligible age group. Selective misinformation about very rare side effect attributed to vaccine and general distrust in sound scientific principle have been the major reasons. Beside the large phase 3 clinical trial, which has proven the efficacy of the currently available vaccine, we have now real world data which shows the effectiveness of the vaccine. In the recent released statistics from the Indian Council of Medical Research post January 16, 2021, when the vaccine became available in India, 51 lakh COVID-19 infection have been reported in the general unvaccinated population at a probability of 0.37%. During the same time, only 5,709 infections have been reported among the subset of 1.74 crore people who have been fully vaccinated against the COVID-19. This implies an almost 12 times lesser chances of catching infection of COVID-19 in you if you are vaccinated. Not only this, even if you get infection, the chances of developing severe life-threatening illness are almost nil. This has also been demonstrated in the real world data by the United Kingdom, where they found that since the start of the vaccination in their country, over 74,000 patients have been admitted to various hospitals with moderate to severe COVID-19. Out of this subset, only 32 patients received a single dose of vaccine at least 3 weeks prior. Rest of were not vaccinated. This data again shows that vaccine works extraordinarily well in preventing morbidity and mortality from COVID-19, even those who might catch the infection due to mutated virus strain. And We must remember the bulk of the doses administered in UK have been AstraZeneca Oxford vaccine, which is also the major vaccine in India by the name Covishield. This data comes as a shot in the arm in the fight against COVID-19, as vaccines are the only proven antidote to the virus. All drug and therapies used in the hospitalized patient are the best, at best supportive. With COVID vaccine rolling out across the world, even as we witness surge among those yet to be vaccinated, now more than ever before, we need to come together and deliberate a way forward. It is safe to say then that this symposium is a significant. I would like to congratulate Dr. Amarjit Singh, Professor and Head, Department of Community Medicine and School of Public Health, Dr. Madhu Gupta, Professor in the same department, in collaborating with the Global Health Strategies and the International Vaccine Access Center at the Johns Hopkins School of Public Health to organize this national symposium during the World Immunization Week. I would also like to applaud the efforts of Policy and Communication Unit at PGI-MER Chandigarh, established with the support from the Global Health Strategies and International Vaccine Access Center at the Johns Hopkins School of Public Health, on its mission to ensure that every family in India is protected from vaccination preventable disease. Over the course of these 2 days, we will have the opportunity to hear from some of the greatest minds on protecting everyone from vaccine preventable disease. From those who develop vaccine to those who ensure that these vaccines reach and benefit all. We have among us a truly august gathering. I would like to express my gratitude to all the speakers, panelists, and moderator who have come together to make these pertinent discussion possible. I also want to thank my colleague at PGI-MER Chandigarh, Global Health Strategies and International Vaccine Access Center at Johns Hopkins School of Public Health for making this forum possible. Together, we can and we will win this fight against COVID-19. Jai Hind.
Thank you, sir. So moving on to our first session, now I would like to invite our first speaker, Dr. Kate O'Brien, Director, Department of Immunization, Vaccines and Biologicals, WHO, to take a session on global, regional and national priorities in context of COVID-19. Dr. Kate served on WHO Strategic Advisory Group of Experts on Immunization Committee from 2012 to 2018. Previously, she was Executive Director of International Vaccine Access Center and Professor of International Health and Epidemiology. Prior to joining IVAC, she has served as Director of Infectious Diseases in the Johns Hopkins Center for American Indian Health. For over 20 years, she has worked in the area of vaccine research on pediatric, maternal, and adult vaccine issues domestically and internationally. It's indeed a pleasure to hear from you, ma'am. over to you.
Good afternoon, colleagues. My name is Kate O'Brien. I'm the director of the Department of Vaccines, Immunization, Vaccines, and Biologicals at the World Health Organization. I'm delighted to be with you today, and I'm looking forward to speaking about setting the stage around global, regional, and national priorities in the context of COVID-19. Just reflecting back 100 years, the world was in the midst of a pandemic with 50 million deaths and 500 million cases eventually suffered in the 1918 influenza pandemic. And fast forward to 2020, about a year ago, when we were at the beginning of this pandemic, with at that time what seemed like an enormous number of deaths, 33,000 deaths, and not quite a million cases. And now 1 year on, over 3 million deaths and over 144 million cases. And this is what the curve looks like of cases globally, with great recognition and compassion for what you are struggling through right now with a serious wave of COVID disease hitting India very hard. And our hearts are with all of those families who have lost loved ones during this period, and great respect for the work that is being done, the commitment to get this pandemic under control in India. I want to use that as the context for speaking about the Immunization Agenda 2030. This is the global strategy for the decade. It was co-created by the global community, requiring broad ownership, all immunization and non-immunization stakeholders, and focusing on both immunization disease-specific initiatives and health system strengthening. It's designed to respond to each and every country, regardless of income level or geography. The most important actions will be the responsibility of country governments, and as a result, it really has to speak to every country. No single agency holds responsibility. This is owned by and the responsibility of all of us. It's a living document to be updated and based on new priorities, challenges, and needs, and critical learnings along the way. IA 2030 sets a unifying vision for the decade aligned with the SDGs and translated into clear impact goals. It's a vision of a world where everyone, everywhere at every age, fully benefits from vaccines for good health and well-being. And each of those phrases maps to an impact goal: reduced mortality and morbidity, leaving no one behind, and ensuring good health and well-being within primary health care and contributing to universal health coverage. IA 2030 establishes a framework to achieve the vision and the impact goals. There are 7 strategic priorities that includes an overarching priority on immunization programs for primary health care and universal health coverage. The other 6 relate to commitment and demand, coverage and equity, life course and integration, outbreak and emergencies, supply and sustainability, and research and innovation. And there are 4 core principles for action. Everything should be designed as people-centered. Country-owned is at the center of this, partnership-based and data-guided. How does IA 2030 relate to the disease-specific initiatives? Well, it really identifies pathways for integration. Countries were really calling for this integration and moving from vertical programs to something much more applicable to all diseases. The measles and rubella strategy has redesigned itself to be reflecting the IA 2030 strategic priorities, and the GPEI, or Global Polio Eradication Initiative strategy, is also being revised and speaks very much to the 7 strategic priorities of IA 2030. The framework for action to achieve this vision and strategy has 4 components to it. The first of the framework for action is planning for implementation. This is supported by technical annexes that describe each of the strategic priorities. The second part of the framework for action is monitoring and evaluation with action-based indicators. The third is ownership and accountability, a framework to drive commitments for action. And the fourth is communication and advocacy to stimulate and reinforce actions across the decade and throughout the decade. And each of these four drives the immunization agenda implementation. Looking specifically at the monitoring and evaluation framework, as I mentioned before, there are three impact goals. And those impact goals have indicators so that we know whether they're being met. There are 7 indicators across the global, regional, and country levels that all of these levels share. For the 7 strategic priorities, there are 21 strategic priority objectives. And the indicators for those strategic priority objectives are available for all of the objectives, but they're for regions and countries to tailor to their own monitoring and evaluation framework based on context. Here, I'm just going to speak about the global indicators and the global targets. So the global indicators, there are 3 for the preventing disease goal, 2 for the promoting equity goal, and 2 for building strong immunization program goals. The targets then overall for IA 2030 for the decade are to prevent 50 million future deaths. Secondly, for all countries to achieve the endorsed regional or global vaccine preventable disease control, eradication, and elimination targets, for there to be a 50% reduction in the number of large vaccine preventable disease outbreaks, for there also to be a 50% reduction in the number of children who receive 0 doses of vaccine through the routine immunization program, for there to be 500 or more introductions of new and underused vaccines over the next decade, and for there to be the achievement of 90% global coverage for the 3rd dose of TTP, the 2nd dose of measles-containing vaccine, the hepatitis B-containing vaccine, and 3rd dose of a pneumococcal conjugate vaccine. And finally, to improve universal health coverage index of service coverage. Now, there are also strategic priority objectives. I mentioned that there are 21 of these, and they have indicators that would specify whether or not we're meeting the objectives of the strategic priorities. I won't go through these in detail, but there are targets that countries will set on selected ones of these. Reaching IA 2030 targets is going to take resources. Most people think resources are financial, and that's true, but there are other kinds of resources that are needed. Technical resources, as well as advocacy and political will resources. And most of these are within country governments. And so this is the most critical aspect of achieving IA 2030, is that commitment from an advocacy and a political perspective, the technical capacity, and the financial wherewithal to achieve these goals. Now, each region is also specifying a vaccine action plan for the decade. The Southeast Asia region has a strategic framework for the decade that includes a vision and a mission, 3 specified impact goals, the same 7 strategic priorities as in the global strategic priorities, and then 31 key focus areas, along with an implementation framework. So the regional strategy shares the vision of the global strategy. The mission is to ensure and sustain the highest level of political and programmatic commitment and community acceptability for immunization in this region to enable countries to achieve national and regional goals and targets with the highest quality technical assistance from regional and country implementing partners. The 3 impact goals for the region are pursuing vaccine preventable disease elimination and control goals, reducing overall mortality and morbidity, and leaving no one behind by increasing equitable access and use of new and existing vaccines. There was a stakeholder survey with over 70 respondents in the region. 81% of the respondents were from the country level. And there was a reasonably high level of priority for all IA 2030 strategic priorities, but 2 stood out: immunization for primary healthcare, strategic priority 1, and coverage and equity, strategic priority 3, were the 2 highest valued priorities. There were 31 key focus areas that were specified in the region, and they fall within the 7 strategic priorities. I won't go through all of these, but simply note that these are the critical focus areas that are the target of the region. Now, I want to put that in the context of achieving COVID-19 vaccination as well, which is part of the set of targets for all regions. This shows just the vaccine uptake, the vaccine doses over time in the region and when different countries started vaccination, shown in the red arrows. And you can see in yellow that the vast majority of the doses that are being administered in the region are being administered in India. And the reason, of course, is this week, India has reported the highest daily number of COVID-19 cases. And we are very aware of the really serious situation of the pandemic in India now and the enormous work that's going on to reinforce the interventions that will work, we know work, and we're shoulder to shoulder with you as and this effort is made to end the acute phase of the pandemic and this wave of disease that is washing over India. India has, as you well know, authorized 3 vaccines for use, 3 COVID vaccines for use. The AstraZeneca product that is manufactured through tech transfer by the Serum Institute of India, the Bharat Biotech product, and then finally the Gamaleya Research Institute product, the Sinovac 5. And I want to celebrate and acknowledge the importance of the domestic manufacturing of COVID vaccines, the development and manufacturing, both of Covishield by the Serum Institute of India and Covaxin by Bharat Biotech. And this is a scientific feat that has taken the world by surprise, that we have as many vaccines as we do that have successfully gone through phase 3 clinical trials and demonstrated their safety, efficacy, and quality manufacturing and reached authorization for use. But this is not, of course, the first time that India has been a leader in the vaccine development space. I want to also acknowledge the pneumococcal conjugate vaccine, the 10-valent that has been developed and is being manufactured in India, WHO pre-qualified already, and improving PCV affordability and sustainable access. And Pneumococcal will be launched very soon. Also, 2 low-cost rotavirus vaccines, and this addresses a leading cause of severe diarrhea, Rotavac and Rotacil, again by Bharat and by Serum Institute of India. And clearly, a critical supply of rotavirus vaccine to assure that the world has the vaccines that it needs at affordable prices. But vaccine development is not the only accomplishment and globally recognized accomplishment in India. So I want to celebrate the elimination of maternal and neonatal tetanus in India in 2016. Also, the major contribution to global health, the elimination of polio in India, with the last case of wild-type polio in 2011, and India removed from the list of endemic countries in 2012. And finally, just as I close, I want to really celebrate the know-how and the success in India of improving coverage and equity of vaccination for all children, assuring that no child is left behind. Mission Indradhanush, launched in 2014, has had the goal to increase full immunization coverage to 90% by 2018 and sustain it through routine immunization, targeting a large number of districts in 3 phases, including an intensified Mission Indradhanush launched in 2017. And of course, the accomplishment is measured in lives saved and measured in coverage achieved and an improvement in equity and an improvement in not only partially immunized children, but fully immunized children, shown here in green. And the 5 critical elements are around meticulous microplanning, capacity building, intensive monitoring, improved communication and social mobilization, and enhanced engagement and accountability at all levels. And the world has learned from you. The world has learned what it takes to find and to immunize and keep children in the immunization program. It's not about just getting a single dose, it's about becoming fully immunized. So let me just wrap up by recognizing that we will be launching IA 2030 on Monday, the 26th of April. We hope that you will join us in that launch. And especially this week, the 24th to the 30th of April, World Immunization Week, with the theme of vaccines bringing us closer to collective progress, closer to understanding, closer to shared endeavors, closer to emotional connections, and closer towards physical closeness, which the world is craving, getting closer to a new normal, closer to stronger public health, and closer, of course, to equity. Thank you very much, and I wish you all the best in the remainder of this important conference.
Thank you, ma'am. Thank you very much for such an insightful session. So moving ahead, we have another session on India's immunization history. So taking this session will be Mr. C.K. Mishra and Dr. Raj Shankar Ghosh. Mr. Mishra has served as Secretary in charge, Ministry of Environmental, Forest and Climate Change, Secretary in charge of Ministry of Health and Family Welfare, and held the additional charge of Ministry of Ayush. Mr. Mishra has more than 30 years of public service and has served as an administrator, policymaker, and public health strategist, holding a wide range of assignments in the field of health, education, industry, and power. Mr. Mishra will be sharing with us the history and overview of Universal Immunization Program and introduction and scale-up of newer vaccines in India. With him, Dr. Ghosh, Senior Advisor, Vaccine Delivery, Bill and Melinda Gates Foundation. He is a physician with 25 years of engagement in public health program policy, planning and implementation. Dr. Ghosh has worked in a large variety of organizations such as World Health Organization, international developmental partners such as PATH and Institute for One World Health, and donor organizations like Bill and Melinda Gates Foundation. His current focus is primarily on advocacy for evidence-based policies and capacity buildings of public health institutions in India. He'll be sharing with us his insights on addressing the challenges in India's immunization program and the way forward. So over to you, Mr. Mishra. We welcome you here.
Thank you very much for that introduction. And since I've been asked to speak about history of immunization in India, particularly with reference to the Universal Immunization Program that we run, I would refer to the two earlier speakers who spoke about the vaccine issue, the current issue of COVID-19. In the COVID background, vaccination has become critical. And I would begin by saying that India has the fortune of being a vaccine leader, as was just being mentioned by Kate from WHO. And this is the time when India needs to actually establish itself globally and strategically as the leader of vaccine manufacturing. And I hope we will be reaching there. In fact, India has had a long history of running one of the largest vaccination program, immunization program that we have in the world. What was the motive? Why did we take this up? We took this up because for us it was critical to save every lives. And the motto was that every death that can be prevented must be prevented. So, I mean, you may have opinions on how much vaccine helps and how much investment needs to go into vaccine. The fact remains that this is one critical tool. Immunization is one critical tool which prevents deaths. And there's nothing better than using a known tool on infants and pregnant women to prevent deaths. This is in the context of a debate that has been going on for a long time. And I would like to flag this today, which is healthcare over hospital care. Vaccination, immunization is a tool which helps you with healthcare so that you are able to prevent hospital care. So our emphasis as public health strategies must be on healthcare rather than on hospital care. Let me just touch on the history of immunization in India. Somewhere around 1978, we had what is known as the extended program for immunization. Then the first real thing started in 1985, which was the universal program for immunization. And this was actually divided in two parts. One part dealing with the pregnant women with 2 tetanus shots, and then other part with infants. And in 1992, we also added the Safe Motherhood program. Now, when we were doing immunization under this program, we were only actually giving out 5 vaccines, which was tetanus, PPT, oral polio vaccine, BCG, and measles. So we were also, as a country, growing at a rate of 1% per year in terms of full immunization. Given the population and the birth cohort in India, immunizing infants is a huge task. But India has been lucky that it has been able to create an infrastructure of both physical infrastructure as well as manpower to actually attend to immunization at the last level. There has been success. Polio has been a success. Smallpox has been a success. Neonatal tetanus has been a success. So there are success stories woven with India's program. But mostly it has been focused on maternal child health issues. So I would say the landmark for getting into this program was the National Health Mission in 2005, which really saw a shift in the responsibility and the work program between the center and the state. And we had a system by which the state proposals were approved by center, and it was on a sharing pattern that the two got together into vaccination, although the vaccines have been provided by Government of India to the states. So parallelly, we've built a very good system of surveillance through the IDSP mechanism. And that is critical when you talk about actually getting to know what is happening where. And IDSP, for example, in the polio program has been extremely helpful. So one of the critical issues in decision making in an immunization in India has been the time length that it takes to decide which antigen to introduce, when to introduce, how to do it, how many states to cover. And this has been, unfortunately, taking a lot of time. Our technical arm, the NTAGI, has been working on it. And but the progress in terms of timelines has not been as desired. We've taken a lot of time. In fact, you look at it, I mean, between 1985 and the introduction of pentavalent, it's been a long, long time. When India decided to introduce pentavalent, which is 5 vaccines into 1, many people were very critical of this, that why are we investing more money because 3 of these are already covered. But look at the solution it found to the logistics. Look at the solution it found to the ease of delivery of vaccine. Just 1 prick to a child. And India has continuously had this problem of not proportionately increasing its resources to continuously increase vaccination. Pentavalent, for example, when it was launched in phases, state-wise, in phases, because we wanted to stagger it so that resources and also availability was an issue. Resources were a limitation. So one of the issues that we need to look at when we talk about immunization in India is how do we best utilize our resources, and what is the proportion of the resource that we need to allocate to vaccination program, to the immunization program in India. 25th of December 2014, was another landmark. We launched the mission Indradhanush. I was privileged to be associated with it, in fact, at that point of time. And what was this? This was a catch-up. It's a catch-up because we felt that we need to now close in on all the missed outs and increase our incremental full coverage from 1% to 10%, 15%, till we come to a 99 to 100% coverage. So the focus was very different. It was not just a replication of the earlier immunization program. We focused on those who were left out. 201 districts and about 90 lakh missing children. We were able to track them, vaccinate them, and I'm told we are now growing at a rate of about 7% per year compared to 1% which was there earlier. The second landmark was April 2016. And you can see from 1985 to 2016, this was the first time when we went out to add 5 more vaccines. We added the IPV, we added rotavirus, we added the pneumococcal vaccine, the JE adult vaccine, and the measles rubella vaccine. Now, in all these additions that India made, we've been able to create a chain of manpower which has been able to reach out to the last. And that is one of the biggest success stories as far as immunization in India is concerned. That we have, instead of people reaching out, the authorities have reached out to people with vaccines, and the initial hesitancy which we saw in polio has now disappeared, and people are accepting vaccines for their children. But again, I'll come to financing. Financing is a major bottleneck. Till now, Gavi was a supporting arm, but now Gavi's role will finish soon. So India has to then start planning to generate and allocate enough resources to immunization program so that we are actually able to vaccinate all the children we want to vaccinate. And then there is this question of building infrastructure. Infrastructure in India has certainly grown, but not at the pace that we would have liked to. And how much have we been able to build is a question. We have some, we are immunizing about 2.7 crore to 2.8 crore children every year. And we have about 27,000 cold chain points. We need to make this more efficient. We need to make them more vibrant, and we need to get more participation in it. And this is where the role of the private sector becomes critical. The role of the private sector in infrastructure building as well as immunization has been limited. We need to create an environment where private sector comes in a big way as supplementary financing to the government efforts. Unless we make that supplementary financing, neither the infrastructure nor the reach will significantly improve. So we need to look at this issue very critically, and both for vaccine immunization as well as infrastructure creation, we need the private sector and any other bilateral or multilateral agency that we can rope in. Because ultimately, the sum total is that we will have to create some supplementary financing mechanism so that we are able to immunize the children that we want to. In fact, it is around that time during 15-16 when we created EVEN. EVEN was able to actually track the vaccines. At that point of time, we had created an electronic platform for real-time tracking of the supply side. But we've not been able to do that successfully on the demand side. So we will need to map that. And Indian immunization has been a huge success story, but we need to keep innovating, to keep adding so that we are able to really achieve good results. And there are two things we need to do. One is keep increasing the basket of antigen. And the second is keep expanding the base of those who are immunizing. If you do this, it prevents death, it prevents morbidity, it prevents mortality, and at the end, it is the economic return that the country will get out of this. I will also touch upon the current issue of vaccination in the context of COVID-19. Currently, we have a vaccination program that is going on. Government of India is running it. We have new announcements of a new age group being joined. We have also a new announcement of opening up some of it to the private sector. So all this is going to create an immunity shield among larger number of people. You know, this entire debate about whether we should prioritize or not, or should it have been opened earlier, I think when you have resources which are not infinite, you will have to prioritize, and preventing death among the vulnerable section is one priority we must look at, and that is how Government of India has looked at it. But equity, which is now being spoken about, is also very critical. But one question that we must answer in terms of the vaccination program, not talking about vaccination and the numbers, etc., because both Professor Jagat as well as Kate has mentioned them. But the issue is, should we as a nation now get to a point where we say that those who can afford vaccination on their own should be on their own, and the government should take care of those who cannot afford vaccination out of their pocket? This is a question which we will need to answer, which will need to be answered both administratively as well as politically. And this is a decision we need to take, because if we really want to race ahead in terms of numbers, it will have to be an open-ended solution. And the private sector in particular will have to join in a big way, increasing their vaccination to a much greater level than what they are doing today. We have the production capabilities, but they need to be augmented, because the sheer size of population of India makes it a daunting task for any production unit to actually be able to fulfill the demand. So we will need to really scale up our production facilities, and the potential in India is huge. We need to tap that. We need to tap the production capabilities. We need to make it affordable. Once we are able to do that, and we need to do it very quickly, because in today's situation, the only saving shield is vaccination. And now the mantra should shift to vaccinate, vaccinate, vaccinate as much as you can, so that at least the population starts getting protected. I mean, it may not prevent it completely, but there is definite protection, as scientists have proven. So we need to take this vaccination story forward. And what I want to say is that this is a story that India has been successful at since 1985. So we have a past, we have a manpower that can do it. It has delivered in the past. And I think if we really pool our resources, we will have a delivery system which is sound and robust in future also. Thank you very much for having me over. Thank you.
Thank you, sir. Thank you very much for your insights. So, I would like to invite Dr. Raj Shankar Ghosh now. Sir, please welcome. The stage is all yours.
Good afternoon. Thank you. Can you hear me? Okay.
Yes, sir.
So, first of all, I would just say that what a delight it was to hear Professor Jagat, Sir, Mr. C.K. Mishra, and Ket about the overview of the immunization program globally and also in India. I would like to speak a little bit about the future of immunization in India, and also hint upon some of the challenges that we might face in the path. When we talk about immunization planning, be it in the past, be it at this moment of time or in the future, there are three elements that we will have to keep in mind. These three elements are what we call the P elements. The first P is a product, which is the vaccine. The second P is a place where the vaccine will be delivered. And the third P are the people. When we talk about the first P, the product, which is the vaccine, vaccines must be safe, efficacious, and affordable to be delivered. When we talk of a place, be it a center, a fixed site, or an outreach center, or as the polio vaccine is delivered at home, the site must be, the place must be accessible and acceptable to the community. That is a learning that we have had from all our immunization programs, particularly from the large campaigns that we have held in India. When we talk about people, there are three sets of people that we must keep in mind. The first, the vaccinators. The vaccinators must be trained not only in giving vaccination, but also in communicating to the public about the benefits, the potential impact of vaccines in their lives. The second set of people are the beneficiaries, the mothers, the children, and now that we are talking about adult immunization, the adults. They must be aware, knowledgeable of the vaccine that they're receiving. If we do not make them aware, if they do not know the vaccine that they are going to receive, the confidence in vaccines will not rise. And if their confidence does not rise, then the demand for vaccination will never come. The third set of people, which are very important also, are the mobilizers. This is a lesson that we have learned from our pulse polio immunization program, from the large campaigns like Mission Indradhanush, of which Mr. Mishra was speaking about, that mobilizers play a very important role in ensuring that all beneficiaries reach the vaccination sites to get their vaccines. Therefore, when we plan an effective vaccination in the future, we will have to ensure that there is a safe, efficacious, affordable vaccine available at a place which is accessible and acceptable to the people, where there are trained vaccinators giving vaccines to people who are knowledgeable about the vaccine that they are receiving, and there are mobilizers who are going to mobilize the people to the center for their vaccination. Now that we have looked at the 3P elements, let us talk a little bit about what is the future of vaccination. As Sir was very rightly saying, that since the past many years, the focus of our immunization program has been to ensure that we have a very high coverage, to ensure that vaccine preventable diseases are reduced, that we have equity, that far-flung areas in the country are captured by immunization. Therefore, the target was primarily around coverage and equity. Moving forward, what we heard from Sir Mr. C.K. Mishra is that India will have to own its own program. It will have to govern the program. It will have to finance the program. It will have to conduct the program. And therefore, the major part of the program, now that we have reached a level which is an optimal level of coverage, around 70 to 80% in most of the states, we will have to think of sustainability. How do we sustain an immunization program as vast as India's universal immunization program? Globally, public health's one of the most important focus today is around universal healthcare, the primary healthcare. Immunization now must become a part of the primary healthcare system of India, largely a part of the universal healthcare. It has always been that, but now the focus must be towards integrating this immunization program into the larger primary healthcare. How do we do that? In order to do that, we need to take care of 4 I's. The first I is integration, of which we will talk a little bit later. The second I is impact. We must measure the impact of our immunization program in order to make course corrections, in order to understand whether the investment that we are making in immunization is giving us the return that we are looking at. And this is not dollar or money investment. It is about the time, it is about the resources. All of those investments we must understand through a very strong disease surveillance program to understand what impact it is having on the reduction of the disease that it is targeting, what is the return on our investment that we are getting. The third I is something again that we heard about just now, is innovation. India is a land of innovations. And when we talk about innovations, it is not only the technological innovations. Technological and non-technological innovations must come forward in order to drive the program. If I just shut my eyes and think of the 2 innovations that I most cherish in my last 30 years of public health career, the first one is a vaccine vial monitor, and the second one is the EVIN that we heard about, the Electronic Vaccine Intelligence Network. Both of these eased the program and increased the efficiency of the program to many, many fold. Such innovations, which are affordable by the country, which are scalable, which can be carried out easily by the health workers, must be brought into the program in order to drive the program. So therefore, we have heard about integration, impact, and innovation. There's a 4th I. The 4th I is institutionalization. India must build domestic institutions in order to run its program. And when I talk about domestic institutions, it is the public institutions, the public sector institutions, like the National Institute of Health and Family Welfare, which is a great institution running many large public health programs in the country. It is our private sector institutions. We just heard about the vaccine manufacturers. It is the autonomous institutions that are there. It is the academic institutions, the All Institute of Medical Sciences spread across the country, the Christian Medical College of Vellore, the site where we are having this conference, PGI Chandigarh. The kind of role that these institutions have played in the immunization program of India is huge. And we must nurture these institutions to take forward India's program in the future. Finally, when we talk about the integration, what do we mean by integration? Where do we integrate? But before I come to that, we must think about how does the immunization program integrate into the primary healthcare program. The immunization program till date has been a standalone vertical program, which has had one target of coverage inequity. When it has to merge and integrate within the primary healthcare program, it must enter in a diagonal fashion, where it does not lose its focus on coverage inequity, but it also embraces the systems part of the primary healthcare so that sustainability becomes easier. We will have to ensure that both the vertical and the horizontal part of a public health program is maintained and a diagonal approach is taken in order for immunization to enter into the primary healthcare. So what are the areas where we can think of it? There are many areas where integration can happen, but let's say that immunization must make a dash for the integration. And what do we mean by dash? Demand, access, supply, human resources. The demand part of the immunization program must be carried out along with the demand for other programs which are of equal importance: nutrition, sanitation, the other primary healthcare programs that are given through the VHNDs. The second is the access part, which is very, very important. We all understand that. The supply part is an important part. There have been many attempts to see whether immunization supply can be merged with the other supplies that are there. It has failed because immunization has always had an unique issue of cold chain and all of those, and therefore immunization has always been a very special kind of supply chain. But we will have to see as to how in the future immunization can actually support other kind of supplies that are there. And finally, the human resource. The frontline worker is ultimately carrying out all of these programs. So we will have to see how immunization is actually fitting into a larger pool of things that the frontline worker does. Finally, I would like to leave with you just one sentence, that when we talk about immunization program, we will have to think of the three basic E's of a public health program. Any public health program that does not include the three E's is not a successful public health program. The first E is obviously efficiency, the second, equity, and the third, empathy. Please remember that immunization program needs an element of empathy when it is being planned by our policymakers and our program planners. Thank you.
Thank you, sir. Thank you very much for such an insightful session. Thank you, both of you, Mr. Mishra and Dr. Ghosh. I would like to invite Professor Madhu Gupta from Department of Community Medicine and School of Public Health, PGI, to give her insights on that. Ma'am, if you want to add something.
Thank you so much. So I would like to thank Mr. C.K. Mishra and Dr. Raj Shankar Ghosh for such a vivid talk and such an insightful talk, taking us from the history to the gains which we have achieved so far, and also to the future, what we need to do. Especially, I really like the very impressive and simple way which Dr. Ghosh has told us the P's, the D's, the I's, and the E's. So I hope that this is a very good message, and I'm really grateful and thank you for your time and sharing your thoughts on this with us. Thank you. Over to you, Dr. Adarsh.
Thank you, ma'am. Thank you so much. So moving on, we'll be going to our next session. So I'll invite Dr. Mrs. Anuradha Gupta. She is the Deputy CEO of Gavi, the Vaccine Alliance. And just let me share her bio sketch with you. So I'll be inviting Mrs. Anuradha Gupta, who is the Deputy CEO of Gavi, the Vaccine Alliance. She, prior to Gavi, Mrs. Gupta served as Mission Director of the National Health Mission of India, where she ran the largest and possibly the most complex public health program in the world, with an annual budget of more than $3.5 billion US. A passionate and influential advocate of women, young and girls and children, Mrs. Gupta played a leading role in India's efforts to eradicate polio transmission, reduce maternal and child mortality, and revitalize the primary health care. So ma'am will be presenting on Protected Together, ensuring life-saving vaccines for all. Thank you, ma'am, for joining us. Over to you.
Hi, everyone. So glad to be a part of this virtual symposium. This discussion is highly topical, as vaccines are in the news more than ever before. The current COVID pandemic reminds us of the power of vaccines, as well as importance of investments in healthcare, and particularly in prevention. But most importantly, the need to leave no one behind, not just with immunization, but with all essential services. That is why the work of organizations like Gavi is so vital. I'm not sure that anyone could have imagined when Gavi was set up 20 years ago that new vaccines would reach millions of children in low resource settings so rapidly and at such massive scale, and that in less than 2 decades, 70% fewer children would die of vaccine preventable diseases. Today, coverage of Gavi-funded vaccines such as Hib, Rota, Pneumococcal is higher in Gavi countries than in the rest of the world. We are also so glad that we could support India in introducing long-awaited introductions of these very 3 important vaccines. And we already see the public health of these new vaccine introductions unfolding. Prior to Gavi, low-income countries received vaccines about 7 years later than their rich counterparts because these vaccines were just too expensive and sometimes not suited to their needs. That is not the case anymore. Pneumococcal conjugate vaccine is a great example which both rich and poor countries were able to access almost at the same time, thanks to the Gavi Advanced Market Commitment, which incentivized large-scale manufacturing of PCV suitable for developing countries. Today, Gavi is the largest purchaser of childhood vaccines, providing long-term stable demand, which is backed by highly predictable financing and very efficient pooled procurement mechanisms. This has enabled us to expand the pool of vaccine manufacturers, half of whom are now in developing countries. And that has improved supply of vaccines and also incentivized product innovations besides highly affordable vaccine prices. Half of our vaccine supplies come from Indian manufacturers who have played a very important role in making vaccines highly affordable. For example, Serum Institute of India supplies Gavi pneumococcal vaccines, a very complex vaccine to produce at a price of just $2 per dose. Its cost in rich countries is more than $100 per dose. Likewise, another Indian manufacturer, Bharat Biotech, is supplying Gavi Rota vaccine at a mere 95 cents, which also costs again over $100 in advanced markets. But as we know, vaccines do not deliver themselves. They need strong health systems, and that is why Gavi support countries to improve supply chains, data systems, capacitation of health workforce, and community demand for vaccines. For example, our cold chain optimization platform has helped several innovations that reduce dependence on electricity and enable last mile delivery of vaccines. In case of India, intelligent digital tracking of vaccines called EVIN, which has now been upgraded to COVIN for COVID-19 vaccine delivery, is another brilliant example of innovations that Gavi pioneers and scales up in partnership with countries. As a result of all these efforts, we have seen immunization rapidly becoming the most equitable health intervention. The number of under-immunized children has been halved since 2000, and 14 million lives have been saved owing to the support that Gavi has been able to provide to 73 lower income countries, including India. As the COVID-19 pandemic tests us on all fronts, the Alliance has built off this long track record of expertise and success in aggregating demand, taking forward pooled procurement and innovative finance. And we have set ourselves a very, very daunting goal of rapid and equitable access to COVID-19 vaccines. The vision driving this global mechanism, which is now called COVAX, is to bring together the whole world in making sure that all countries, regardless of their income or paying capacity, receive enough vaccines within this year to protect vulnerable and high-risk populations. This is essential to avoid a repeat of what we saw with H1N1 in 2009, when a few wealthy countries tied up global vaccine supply, leaving the vast majority without access. Under the banner of the COVAX facility that Gavi administers, we have brought together 190 economies, pooling global demand and volume guarantees, as I said, which are backed by advanced market commitments. COVID-19 vaccines will become the 18th antigen in Gavi portfolio to be rolled out at a speed and scale which is unprecedented in human history. To achieve this, we are focused on four key things. Constantly advocating for global solidarity and multilateral collaboration to ensure fair and equitable access to COVID-19 vaccines, securing agreements with manufacturers to supply 2 billion doses in 2021 to all countries participating in COVAX facility, raising at least $9 billion to provide between 1 to 1.5 billion vaccine doses to those 92 countries that have limited fiscal capacity to buy COVID-19 vaccines themselves. And then also supporting these 92 countries to effectively deliver these vaccines to priority groups. As you can imagine, this is a mammoth undertaking. But let us not forget that the collateral damage of COVID-19 is colossal. Health systems are overwhelmed, essential health services are disrupted, and deaths from other diseases are increasing. The knock-on impact on childhood vaccination in lower income countries and vulnerable populations has been devastating, with millions of children missing out on timely, life-saving immunization. There is a grave risk of a very sharp increase in infectious diseases, deaths, and medical impoverishment. By sustaining routine immunization, countries save at least 84 children lives at the risk of one COVID-19 related death. So we are really focused on helping countries maintain focus and commitment to routine immunization as they deliver COVID-19 vaccines to priority groups. Otherwise, we will see another tragedy unfolding, which is far greater than the current pandemic. We know that 2 million more children could die in a span of 12 months, just because of disruption of health services and indirect impact of the pandemic. We must shape our COVID-19 response as an opportunity to achieve better equity and social justice. I really feel that the unprecedented scale of COVID-19 vaccination offers us a unique chance to focus on those people who live in fragile, conflict, humanitarian settings, as well as those zero-dose children who do not receive even a single vaccine shot and account for 50% of child deaths. That can be so easily prevented with the use of vaccines. Even before the pandemic, 20 million children born every year remain deprived of the basic vaccines, with 2/3 not even receiving a single shot. These zero-dose children embody communities that face compounded vulnerability, poverty, gender barriers, stigmatization, low access to education, nutrition, also sanitation, hygiene, water. And in a historic decision, therefore, the Gavi board in December last year approved $500 million in dedicated funding to reaching these zero-dose children so that we can actually, in the next 5 years, bring laser focus on supporting countries to identify zero-dose children, reach them sustainably, monitor and measure progress closely, and advocate for continued prioritization of zero-dose children and communities. Gavi, as you are aware, is very committed to equity in both COVAX and our new strategy. And therefore, we are going to leverage every potential opportunity to make sure that we reach these zero-dose children with all antigens as well as other essential health services. We really think that integrated approaches will be essential to leverage the synergies, and COVID-19 vaccine provides a fabulous opportunity to do that. More COVID transmission means more variants, more adaptations of vaccines, potentially more boosters, more funding, more time for economic recovery, and meanwhile, more poverty, more hunger, more deaths, not just from COVID, but disruption of essential services. And there is a risk of reversal of hard-won gains. So as we combat the pandemic, let us use COVID-19 vaccination as an opportunity to do a complete reset on how we do business and build back better with more equal, more inclusive approaches that leave no one behind. The question is not whether we can afford to do it. The question is whether we can afford not to do it. I thank you for your attention.
Thank you, ma'am. Thank you for such a beautiful talk. It's really enriching. So now we have a panel discussion scheduled titled Leaving No One Behind, Achieving Immunization Commitments. Before I introduce you to the moderator, I would like to request the participants to drop their queries using the question and answer features over there. So to moderate the session, I would like to invite Professor Madhu Gupta. She is, just give me a second. So she is a professor of community medicine in Department of Community Medicine and School of Public Health, PGI, Chandigarh. She has contributed over 100 publications and has led over 50 research projects. Her area of interest include maternal and child health, vaccinology, and health inequities. Dr. Gupta was recognized by the international publication Vice as one of the humans of 2020 across the globe who have made a difference in the lives of people during COVID-19 pandemic. Dr. Gupta is a member of subgroup on maternal immunization under National Technical Advisory Group on Immunization, New Delhi. I request Dr. Madhu Gupta to introduce the August panel and moderate the session. Over to you, ma'am.
Thank you, Dr. Adarsh, for the kind words. So let me introduce the esteemed panelists in this session. So I would first like to introduce Dr. Pradeep Haldar, who is a former Deputy Commissioner of Immunization Division at Ministry of Health and Family Welfare. And currently he's an advisor for reproductive and child health. In the ministry, he brings in vast experience from the public sector and has extensive knowledge on the government's efforts around immunization health systems. Second panelist is Dr. Mathuram Santosham, but somehow he will be joining us through his session after the panel discussions are over. He's a professor and senior advisor at the International Vaccine Access Center at the Johns Hopkins School of Public Health and helps to formulate and guide IVAC strategies and mission. And I really feel proud that I've worked with him in implementation of pentavalent vaccine in India. And we generated the evidence related to Hib disease in the country. Our next panelist is Mr. Neeraj Jain. He's the country director at PATH. And PATH, as most of us know, is a global health organization that seeks to accelerate health equity so that people and communities have the chance to thrive. Welcome you, sir. Our next speaker is an international speaker, Dr. Sawitra Kosen. He is joining us from Indonesia, and he's a senior policy researcher at the National Institute of Health Research and Development, a subunit of Indonesia's Ministry of Health. He conducts extensive on-ground research focusing on the cost effectiveness of vaccines and healthcare system strengthening, among other areas. So I welcome you, all the panelists. So first of all, I would like to invite Dr. Pradeep Haldar for the panel discussion. And the first question, sir, is will be focusing on you and your thoughts on that. As the previous speaker, Mrs. Anuradha Gupta, has mentioned, she has already set the stage for that. That in spite of the COVID-19 pandemic, we have to innovate. We have to find ways to continue the routine immunization. Otherwise, we will be heading towards something much worse than this stage, probably, with respect to the children health, and with respect to disrupting the routine immunization. So, sir, and as we have also learned from Mr. C.K. Mishra regarding the mission in the Dhanush, how we could contribute, we could increase the coverage every year to 7%. That is a huge increase, and we have a very good coverage of 70 to 80%. And now we are starting with the intensified mission in the Dhanush phase 3. So I would like to know, sir, what are the key priorities under the intensified mission in the Dhanush 3? And can you share how this latest launch will help India build on the gains made to ensure all vaccines, new and as well as old, reach 100% of the target beneficiaries, considering the current pandemic situation as well? Dr. Pradeep Haldar. Sir, we are not able to hear you.
Sir, please unmute. No, sir, you are not audible yet.
Meanwhile, maybe we can connect with him, or is he ready? Maybe we can move to Mr. Neerajan till that time, just to save the time. Sir, PATH plays a critical role in delivering life-saving vaccines to all. Can you share how technologies and innovative service delivery mechanism have helped us improve immunization coverage and scale up new vaccines in the past few years, and how it envisages to continue to be doing that in the future as well?
Yeah, thanks, Madhuji. Thank you so much for inviting me. And I hate going before Dr. Haldar because he is the lead of our immunization program in India. But while he gets his mic going, I'll just talk a little bit about the innovations. Firstly, I think India has a lot to celebrate, and all the speakers before me have talked about that. I would like to sort of reiterate that we've really achieved a lot. I think we are also pretty much clear in this group, at least, that immunization is one of the most cost-effective and critical sort of public health interventions that we need to focus on going forward. We've got a polio-free country. We've managed to eliminate maternal neonatal tetanus. So a lot of things to actually be proud of. In terms of innovations, in the whole chain, there are multiple innovations. And PATH has been working on actually a lot of this. I was actually surprised when I was preparing for this talk about how we've been involved with practically every part of that innovation. I'm going to talk about vaccine development and what's been going on there, and lots to celebrate. There's data for immunization. I'm going to talk a little bit about the cold chain itself. And also, going forward, the delivery mechanism. So does it necessarily have to be through the cold chain, or are there other innovations in the pipeline? I'll talk about a few of those. And also a little bit about the future, where we are going and what needs to probably evolve. And I'll build on some of the things that have already been said. So coming back to the vaccine development piece. Path has been part of developing the Menafrivac vaccine with Serum, as well as partnership with WHO, which was one of the most, I would say, most impactful vaccines to deal with meningitis deaths in Africa, in sub-Saharan Africa. It also was the platform where Serum actually really sort of shot up in the global, positioning, which I think we are still very proud of, and it's really good to see them taking that on during COVID. We then partnered with Bharat on their rotavirus. We partnered with Serum on their rotavirus. We've heard lots of the impact of that, how the cost came down. And these are extremely important points to remember as we're going forward, because this is what has increased access. This is what has reduced the price, because of which we're able to save many more lives, especially in low and middle income countries. We also worked with Serum on their PCV, which is now WHO pre-qualified, and it's, Anuradha ji talked about that. The Japanese encephalitis vaccine, which is such a critical part of the program in multiple areas. So the point I'm trying to drive is innovation in product development is absolutely key, and innovations in product development at the country level is what's going to drive us forward. Couple of other things that just want to mention, two great innovations that came out. One was the vaccine vial monitor, that little sticker on the vaccine, which tells you when there's been a thermal shock. And the second was the auto-disable syringe, which is so critical at this point. So, we have a lot to be proud of in terms of success in the whole immunization program in the product development side, but still, of course, lots to do. Path has been very involved with the COVAX facility also. Going forward, a couple of things that we are currently working on. One is the novel oral polio vaccine for the worsening type 2 polio virus. So there's product development happening towards elimination. Also, we are working with a consortium. This is very interesting because on the COVID vaccine, there are still access issues. And if we pick up the newspapers right now, you see lots of issues with pricing and how the costs are going to pan out. So we are working with developing country vaccine manufacturers to look at a new COVID vaccine, which is based on the egg-based Newcastle disease virus platform, which is really the influenza platform, and which will not only reduce the cost by probably more than 50% of what it is today, but also increase access and also increase manufacturing in smaller countries. So that could change, that could be a game changer. So lots of work on that. Moving on to data. I think India has done brilliantly. The whole EVEN platform, moving into COVID, there have been, of course, you hear about challenges with COVID, but it is still the best that I can find anywhere in the world. So, congratulations to the government of India for that. And I think just going forward, I think this could be the basis of our electronic health, register, because with the COVID vaccination, we're actually collecting so much information that this could form the backbone of that. And that's something that I would like to say, because data just for immunization is not helpful, but data of public health, when triangulated with immunization, would be extremely, extremely useful for India as a country moving towards better health. And going back to what Raj talked about, the integration to primary health, I think I would sort of push for that. Moving on, I'm going to talk a little bit about the cold chain. Big conversations at the moment about cold chain, -60, -30, +8. I know we've been seeing all these degrees all over the place. Having said that, we have one of the best cold chain structures in the 2 to 8 degree category. Is that the way forward? Are there changes to be done? I think those are the questions that we should be asking. There are challenges with the current structure because the final 20% that we are trying to get to are in hard to reach areas. Our boxes are not going to be able to carry them. So we've been working with a technology called Black Frog, which has a built-in refrigerator carrier, which could actually reach the hard to reach places up in the mountains and beyond. I think Another innovation is a freeze preventive vaccine carrier. A lot of times ice packs are freezing vaccines. So, there's a small thin layer which protects the vaccines from getting frozen and thus increases reduces the wastage from vaccines because of freezing. We're also testing a lot of ultra cold chain equipment. Can we get to the -60s? Can we look at how that could work? There's also a lot of work going on in multiple delivery mechanisms. I just want to spend a few minutes on that. Nasal, we are all hearing about it. And actually for COVID, nasal could possibly be the game changer if you have an intranasal delivery mechanism for a vaccine. It could also be a game changer from a perspective of the supply chain. How does that move? It improves access coverage hugely, but not only that, but it can also be more effective if it is administered through the nose. So that's an area where a lot of research is happening. Path is involved in some of that. There's also microarray patches, little stickers, band-aids to actually be able to deliver on vaccines. Again, lots of work happening on that. We hope to see some of that extremely soon. Then, of course, oral. I mean, we know what happened with the polio when it went oral. That was the only way we could have eliminated polio. Probably wouldn't have managed if it was injectable. So oral rotavirus is also a game changer. And that's another area which we need to continue to develop on that. I'm sorry about that. So that's another area where we need to continue to develop. So I think, there is that whole thing of how is this getting delivered. Another interesting product that we worked on is something called, on the microarray patches. What it does is it makes delivery pain-free. It generates better immune response. It also reduces the vaccine wastage. It removes the temperature challenges because it'll be temperature stable. It also is self-administrable. So actually you can just buy it off the shelf and use it yourself. You don't need to have a full mechanism for delivery. So it could go very, very well. Finally, Pharma Jet. It's a very interesting product we worked on, which is actually, it pushes a narrow stream of fluid, which goes through the skin without any kind of an injection. And that's another interesting technology that could be used going forward to improve vaccination. Just to close what I'm saying, and I see Dr. Haldar's mic seems to be working, so I'm just going to quickly close. I want to hear him. I think the private sector has been talked about. I think COVID has given us an opportunity to actually pivot from a pure public health immunization program to a hybrid model of immunization. I see no reason why people who can afford to pay should be funded by the government. On the other side, I see people like us, like all of us on this panel probably, should be subsidizing, cross-subsidizing for people who can't afford it. And the government should not necessarily bear the brunt for all of it. So there's a lot of opportunity in the private sector, and I'm looking forward to Government of India pivoting there and using COVID as a great opportunity, because we've already pivoted. We've probably been forced to pivot, but since we've pivoted, let's keep the momentum going. I'm going to stop there. Thank you, Madhu.
Thank you so much, Mr. Jan. That was really insightful, and I am quite hopeful. The aim, the objective of leaving no one behind. If I think by collaborating with such organizations who are doing such technological innovation, so we can reach everyone. I think that dream, that hope, that mission, it looks quite achievable. So let's hear from Dr. Pradeep Haldar, sir, regarding intensified mission in the Dhanush phase 3 and how what the government is planning on that. Yes, sir. Over to you, sir. Some issue again. Sir, maybe you can take out your headphones and you can just straight away talk. You can take out your headphones, sir.
Am I audible?
Yeah. Now you are audible, sir. Thank you.
Thank you very much. Sorry for the technological glitch. So when we look at the immunization program in the country, and when we look at the last polio case, which was there in 2011, and the country was certified polio free and was taken out of the endemic countries in 2014. And then we were also maternal neonatal tetanus eliminated, been certified in 2016. We needed to move forward. And we were looking at the immunization coverage, and we were seeing that our immunization coverage was quite low. And in the 2009 to 2012, that's the period when we saw the immunization coverage moved at a rate of almost 1% per year, or there was an increment of full immunization to around 4%. And that was the time when the thought process came that we need to strengthen routine immunization, and we need to see something that needs to be carried out. And therefore, in 2014, December, the Mission Indradhanush was conceived and launched on 24th of December 2014. And in 2015, we started with the Mission Indradhanush. The basic aim of the Mission Indradhanush was we were looking at various data in terms of where are our BPD cases, where are our low immunization coverage. And specifically when we talk about low immunization coverage, we were also having concurrent monitoring, which was actually moving into the field and going into the communities and trying to find out where are the children who has missed out immunization coverage. And based on those concurrent monitoring data, based on those centers or sub-centers where session has been missed out for 2 to 3 months, based on where the VPD coverage, I would say the VPD outbreak reported. So we mapped out the country and we started with Mission Indradhanush. So we started with Mission Indradhanush in 201 districts as a first phase, and thereafter we continue to identify this as one of the strategies to strengthen routine immunization. So while we were focusing on routine immunization throughout the year, but we will continue to have at least one campaign of 7 days into 3 consecutive months. And during this period, we were looking at those pockets where the coverages are low, those pockets where there are large number of BPDs, those pockets where concurrent monitoring indicated that children were missed out. So these were various indicators being used to identify those pockets, and we carried out mission in those pockets. Till date, we have carried out almost 10 such rounds. I would say that somewhere in 2015, we also had Gram Swaraj Abhiyan. That's where we were looking at almost 16,000, 17,000 odd villages where we carried out the special immunization drive, and then the aspirational district, 117 aspirational districts. Also, those are the districts where we carried out Mission Indradhanush. So that was an intensified Gram Swaraj Abhiyan. And all those parts actually led to an increase in the immunization coverage in absolute terms. When we look at it, we had covered almost 3.85 crores children over these various rounds, and almost 96.8 lakh pregnant women have been covered. But what was the impact? When we looked at the Mission Indradhanush first 3 rounds, we also carried out a survey called Inches. And we wanted to see with the respect to baseline and what was the improvement in immunization coverage in those 3 rounds of Mission Indradhanush. And we saw that almost 6.7% full immunization coverage was there in those districts where we have carried out Mission Indradhanush. Later on, we also carried out another survey in 2018-19 in 190 districts where we have carried out the Mission Indradhanush. And we looked at these districts where the full immunization coverage was less than 90%. None of the district has 90%. And we could see that in these districts, there was an increase of 18.5% increase in the full immunization coverage. There was at least 10 districts which has gone more than 90% full immunization coverage. So we could clearly see that there was an impact in the full immunization coverage. Recently, when we look at the NFHS 5 data, National Family Health Survey 5 data released for 22 states, and NFHS 4 is 2015-16. That's the time when we have started Mission Indradhanush. And when we have seen the data of these 22 states, we have clearly seen that 18 states has increased in the full immunization coverage when it's compared to 2000 and I would say NFHS 4, which is 2015-16 data. So clearly indicated that there has been an improvement in the immunization coverage. When we talk about COVID, In the COVID period, in last year, in the March 2020, suddenly the immunization, I would say, had come to a standstill because of the fact that the entire country was in the lockdown. So we said that we need to do something to see to it that the immunization coverage does not also becomes a standstill, and we need to increase it. So we came out with a strategy, and the strategy that we had was that areas which has lockdown, obviously people cannot move out of their houses. So what we have said that in these places, when people are going for their delivery services at the institution, that's the opportunity which is already there. So the newborn kids who are born into these hospitals, they must continue with the immunization services at birth, which is basically the BCG, the OPV, and the hepatitis part, which is given at birth. So these three vaccines were continued to be given even during the lockdown. And then we also came out that wherever there is no lockdown, and these are the areas where we actually said that you have to continue with the immunization services for those who walks into their centers and provide the immunization services. So when we have compared the month by month data of 2019 versus 2020, we could clearly see that in the month of March and April, there was a bit dip in the immunization coverage for some of the antigens, but subsequently we have picked it up. We continued this, and we knew that wherever we are missing the children, we need to vaccinate them. And that is where Mission News 3 came into the play. And in the month of February and March, we actually carried out again a mission in the nose and looked into those pockets where we have missed out those children, and we have carried out these activity in this particular phase. In the current year, we also have been looking into the two things. While we are looking at such a massive, I would say, vaccination drive for COVID vaccine, which is ongoing across the country, we are also looking at expanding pneumococcal conjugate vaccine, which is at present, which we started in 2017. And now I would say we are planning to expand it to all 31 state and union territories in this entire, I would say, about 9 to 10 months. This will be expanded to all these 31 state and union territories. So when we look at 1985, when we started with the expanded program of immunization, at that time we had 6 vaccine preventable diseases for which we are giving vaccines. Today we are giving almost 12 vaccine preventable diseases for which we are giving vaccines, of which 10 are nationwide. One by default is JE, which we are doing it only in the endemic districts, and today we are covering almost 300 districts which are part of the endemic JE districts and giving them with the JE vaccine. And the second is the pneumococcal conjugate vaccine, which is at present in the 5 states, but by the end of this year, we will be seeing this PCV vaccine being expanded nationwide. So those are the roadmaps, and that is how, and we need to see that while we are implementing immunization program, we need to see and generate evidences from the field, so that when you say improve immunization coverage, we should have evidence-based immunization coverage. And that's where we are relying more on the concurrent monitoring. We are really asking the states to actually have a proper sampled way of doing the concurrent monitoring, so that you build up the evidences and then you know what are the gaps and exactly cover those areas. Thank you, and over from me.
Thank you so much, sir. And that's something to be really feel proud of the ministry and proud of the efforts which were taken to reach to almost each and every one. Sir, I would like to, sir, take another minute of yours, sir. Considering the current COVID-19 pandemic, do you think that it will be challenging? And do you think that if suppose we are not able to continue or some disruption is there, we will be able to cover that in the later months? Maybe not now, but definitely will be covering them. So
see, while we are looking at the pandemic and looking at COVID vaccination, so we are clearly articulating that the COVID vaccination and the COVID centers should be not overlapping with the immunization centers and immunization places. So very clearly articulating from day one that COVID vaccination should be in addition to the other vaccinations that we are carrying it out, and not that the COVID vaccination should be built upon the immunization session sites and you carry out in the COVID vaccination immunization. That would would mean that you are disrupting the routine immunization. So that articulation has been right in the beginning, that while the COVID vaccination will be an year-long drawn processes, but we also need to continue with the routine immunization. And we are continuing to focus on the routine immunization and trying to strengthen on the routine immunization activities. And I would say that while we are doing this part, we may have another mission later on this year.
So thank you so much, sir, for your thoughts on that as well. So moving on to our next panelist, Dr. Suwitra Kosen from Indonesia. So recently Indonesia have also planned to roll up pneumococcal vaccine in their country, and through the Gavi commitment, advanced market commitment, they have received this vaccine. And I would like to hear from you, sir, that how do you envision the rolling out, and India can learn from your experience also, and what challenges do you envisage, and what strategies have you planned to overcome this expansion related to pneumococcal vaccine, because it will be really useful for India as well, because that is what we are also planning in the months to come.
Thank you, Doctor. Basically, we already aiming to start the vaccination more than 2 decades actually, but because of the price of the vaccine, we have to postpone until we graduated from Gavi. So it's good that Gavi with AMC still can support us. So we already received 1.6 million doses of the PCV 13. But before that, actually, we already starting the demonstration project in 2 provinces in Indonesia. That's in West Nusa Tenggara and also in Bangka Belitung province. But we purchased that using market price, very expensive, basically. That's about $20 per dose. And you know, our baby cohort, newborn baby every year is 5 million almost. So basically, if we have to purchase through the market price, it will absorb all the immunization budget for all other vaccine. So it's good that we hope this Gavi AMC can support us also in the future, at least for 1 decade or more, if possible. Because if not, the government will be reluctant to fund it because of the big cost, because of the large cohort also of babies in Indonesia. Besides that, actually, our biopharma, our vaccine factory, already discussing with the SII, Serum Institute of India, about possibility for the transfer of technology of PCV in the future. We still don't know about the fate of that, but we just hope that it will work, that one. Besides that, actually, we started promotion of the PCV because we realized that the streptococcal attributed to burden in Indonesia is quite significant. And we hope the herd immunity effect of PCV will help to improve our health status of the population for all ages because of the externalities of the vaccine. Besides that, we also doing some cost effectiveness analysis of the PCV, comparing with no vaccine, and it showed very highly cost effective actually, even with the market price. So with the Gavi AMC price, it will be, of course, very cost effective. So by doing that, actually, we hope we can fighting not only pneumonia, but the other also, like septicemia, also meningitis, and acute otitis media related to the streptococcus. I think I stop here. Doctor.
Thank you so much, sir, for sharing your thoughts on pneumococcal vaccine and how excited I think the country is to get this vaccine, and you're looking forward to now scale it up in the whole country. So with this, there are a few questions from the participants which I would like to take up. So one is, I think it is addressed to Mr. Neeraj Jain. The participants say, "Hi, I'm just about to join as an immunization consultant for COVID in Northeast India. Can you please share your views on the challenges on vaccine delivery mechanisms in hard to reach areas? Also, do you think innovations like drone deliveries are around?" By Ruchi Verma. So yeah, and maybe Dr. Haldar after that can add, because this news also I've heard like they are maybe planning drone delivery of COVID-19 vaccines. Yes, Mr. Jain.
Yeah. Thanks, Madhu. Thanks for the question. I did respond on the chat box, but I'll just quickly repeat. So the drone delivery mechanism is absolutely very interesting, but there are huge challenges because of DCGA and restrictions of flying drones, especially in sensitive areas. So, that may be a bit of a longer shot, maybe not for COVID immediately. I don't think you'll get permissions that quickly. What we are working on actually in the Northeast is something called Black Frog, which is a small carrier which has a refrigerator, and that can be used for reaching out to hard to reach places. We're testing that out. We'd love to be in touch with you as you go forward there, but that might be the solution for those hard to reach areas for now. Drone delivery probably in some time. I'll stop there. Over to Dr. Haldar if he has some ideas.
No, I think so. You have rightly pointed it out. Drone delivery, we were thinking for quite some time in the routine immunization, but there are challenges. There are regulatory requirements in terms of at what height the drone can fly, and what are the pathways that drone can fly. All those regulatory things are there, and working on those drone delivery systems, one has to think it over. But I would say the challenges are also different in northeastern state, where 6 months there is rainy season, and that's the period when the area gets cut off, and they have very soft hills. So most of the northeastern states are hilly terrains, and because of those rainy seasons, the people are not able to move from one place to the another, and would mean that September month till March, April is the maximum opportunity period one can access within the Northeast different districts and deep inside, and can carry out vaccination program. And other 6 months period is quite difficult to move into those terrains and provide services.
Thank you. Another last question I would like to take, although the question is addressed to Mr. C.K. Mishra. If he's there, he can respond. Otherwise, like panelists are free to respond. India is offering immunization to more than 95% by public sector as free of cost. In order to promote private sector to contribute more in UIP, don't it undermine the effort so far achieved by bringing the cost factor for vaccination service? So this is by Dr. Subhash Godra. I think he's our MPA student currently.
Let me put it up. When you are looking at immunization program, and when you look at the immunization schedule in the country, though in India we have a national immunization schedule, and that has been followed up by the national immunization program, but then the schedules by the different practitioners are slightly different. Let me say, for example, when we were looking at the polio eradication and looking at the IPV also as a part of the polio eradication program. So we were looking at IPV introduction as one doser or two fractional dose in the national immunization program as a part of the polio endgame strategy. But many of the people would give 3 full doses of IPV, and therefore those schedules were one issues where the things are not what I would look at. National immunization schedules and the schedules followed by many of the practitioners are different. Nevertheless, when we look at the penetration into the rural part and penetration in the other parts of the country, we see that our national immunization program almost caters to 95% of the cohort that is there, and the private sector presence is on 5%. As far as Government of India is concerned, it does encourage the private practitioners in supporting the immunization program, and any private practitioners who would like to coordinate with the national immunization program, government is always willing to give them free of cost the vaccine, with the certain conditions that these services has to be, and these vaccines has to be given free of cost to the beneficiaries and not they are being charged. So any private practitioners who would like to join the National Immunization Program and join hand with the national program, they are welcome, and we coordinate with them at the local level, at the district level, at the state level, and we always encourage them that they can participate. Over from my side.
Thank you, sir. So I don't think that it will have more impact on the cost in general, because it will be for those who can afford it. They can get it from the private sector, but it will not impinge on the poor. Those who cannot afford it, they will be definitely be going to the public sector, and public sector is not going to refuse. So with that, we come to the end of this panel discussion, and it really was very insightful, and I felt that we can actually achieve the goal of leaving no one behind. So with that words, thank you, Dr. Pradeep Haldar, Mr. Neeraj Jain, Dr. Kosen from Indonesia. Thank you so much for joining us. And with this, I would like to stop here. Over to you, Dr. Adarsh. Thank you so much.
Thank you.
Thank you. Thank you, all the panelists. Thank you. It was indeed a very full session from you. So moving ahead, we are going to have a next panel discussion. So may I request Dr. Amirullah Khan to moderate the session on integration, impact, innovation, investment, and institutionalization, lessons from COVID-19 on working together. Dr. Amirullah Khan has worked on development issues primarily in the health, education, agriculture sectors. He's a former policy advisor to the Bill and Melinda Gates Foundation. Dr. Khan is a visiting professor at the Indian School of Business at Nalsa in Hyderabad, and a member of Board of Governing Commission of Inquiry on Socio-Economic Conditions. Professor Khan edits Sage Journal of Development Policy and Practice with Dr. Bobby John. So over to you, sir. Please, you are requested to invite the panelists and moderate the session. Sir, you are not audible.
Okay, can you hear me now?
Yes, sir.
Oh, thanks, Adarsh. Thank you so much.
Thank you, sir.
I had just started saying that it is so nice to have such an august panel with me here, and this panel is going to deliberate, as Adarsh has said, on how we are going to learn from lessons on COVID and see how we can work together. And therefore, we have for you this absolutely fabulous group of people who embody what working together means in today's context. We have Dr. Nivedita Gupta. Dr. Nivedita Gupta is from our most premier research institute, the Indian Council of Medical Research. Is a senior scientist in the Division of Epidemiology and Communicable Diseases. She's going to, obviously tell us what we want to know about working with the private sector. We've come a long way now in developing public-private partnerships, and this is one area where we have seen such a wonderful coming together of the two sectors. Dr. Gupta did path-breaking work during the Nipah virus outbreak, and therefore knows far more than most people I know about how pandemics are to be treated. And in her role as a key member in designing treatment and testing protocols for the country, Nivedita has been a pioneer. Welcome, Dr. Gupta, and thank you so much for accepting this invite from us. My very dear friend, Shirshendu Mukherjee, unfortunately fell ill and has contracted what all of us dread, and therefore had to be excused from today's webinar. But he has sent his really eminent colleague, Dr. Neeraj Singh, who's a senior manager at the Biopharma Mission, working very closely with the Gates Foundation. Welcome, Dr. Singh. Thank you so much for taking this up at such short notice and filling in big boots, I must say, just to put some pressure on you. But I'm sure with your rich experience in everything you've done in terms of biotechnology and in working in the antibodies that we now hear about, most laymen who hadn't heard of trastuzumab and so on are going to benefit from listening to you. We, of course, have two of the foremost private sector players today, internationally known, who we are indebted to not only in India but across the world. Dr. Suresh Jadhav, Executive Director at the Serum Institute of India, and Dr. V. Krishna Mohan at Bharat Biotech. We all know, and I don't want to go into details, we all know the kind of work that these two gentlemen and their organizations have done in bringing to us a vaccine at the fastest pace possible. We've never seen a vaccine developed, tested, and rolled out within a few months of even the first strain being discovered. So it's just mind-boggling. When 100 years later, when people will read this history, they will still marvel at what was achieved with this spectacular coming together of great minds. So I'm going to get to the panelists now. See, we have very little time. The previous session has eaten a little bit into hours, so we'll have to be very, very precise. We are going to talk really about public-private partnerships, because that's the core issue. And as we grapple with this horrible pandemic across the world, the solution seems to be only through developing and strengthening and deepening these public-private partnerships. So let me first get in Dr. Gupta, Dr. Nivedita Gupta. Dr. Gupta, in your experience, particularly, the fact that you head this division at ICMR, that you worked in Kerala, you've really worked at places which matter and which have been the case studies for the rest of the world. So what has been your experience? What is your take on this discussion on integrating and institutionalizing our partnerships? Over to you.
Thank you very much for this opportunity. So I'll just give a glimpse of a few public-private partnerships which really helped us to at least fight the COVID-19 pandemic in the most effective way as we could have done. So first of all was testing for COVID-19. And as you know that India adopted various platforms for testing and increasing the outreach of testing for COVID-19. So initially, when we started facing the challenge of this pandemic way back in January 2020, we only had one lab at National Institute of Virology in Pune. Yes. Now, seeing the size of the pandemic, we quickly scaled it up to 118 virus research and diagnostic labs, which we had in India through NIV Pune and our efforts at ICMR headquarters. But soon we realized that even a network of 118, 120 labs would be grossly insufficient for a country like India. Mm-hmm. So in middle of March, we developed a very effective partnership with the NABL, and we onboarded all the NABL private laboratories which were accredited by NABL for molecular testing of viruses. And the numbers were very few. But then this partnership with NABL and the very encouraging forthcoming role of the private sector, private laboratories, really helped us to quickly onboard, get NABL accreditations and onboard hundreds and hundreds of labs into the COVID-19 testing network of ICMR. And as we talk today, we have more than 2,480 laboratories all across the country within a short span of a little more than a year now. And of this, almost 1,450 are RT-PCR laboratories. And the testing share, as we say that the country's capacity is to test 15 lakh RT-PCR samples per day, the testing share of private laboratories remains around 30 to 35%. And a significant amount of our network consists of the TrueNat and CBNat systems also. So besides the NABL and the RT-PCR big laboratory chains coming into play. The other very nice example of public-private partnership in testing is the TrueNat system that we could quickly accredit, like we could validate the different TrueNat cartridges, the standalone screening cartridge, then multiplex confirmatory cartridge, and with a very quick partnership and very effective validations, we could quickly bring the TrueNat system also into the COVID-19 testing program. And that's how we could increase the access and outreach of testing to the district level also. Because the various machines which were there for TB testing could be very quickly repurposed and brought into the COVID-19 testing program of India. So that also worked phenomenally well. And the another example is that way back in March 2020, we really had a dearth of testing commodities, wherein we were hugely dependent on imported kits and reagents for testing. Now, when the pandemic grew in various parts of the world, India became high and dry as far as testing commodities were concerned. That's where the private sector chipped in, and with support from various other government departments, the various private players came forward and started manufacturing indigenous diagnostic commodities, which really made India self-sufficient. They came forward, they manufactured the RT-PCR kits, VTM, swabs, and even the rapid antigen test kits. And with this tremendous effort of the private sector and public-private partnerships, the cost of the testing in India came down from more than 1,700 rupees to now less than 150 rupees for a single RT-PCR testing diagnostic commodities. So these are excellent examples how the public-private partnership worked as far as testing is concerned. And then the other living example, like Dr. Krishna Mohan from Bharat Biotech is here. The way ICMR and Bharat Biotech came together for the development of Covaxin, I think that is phenomenal and that is historical, right from the isolation of the virus and like every step, the preclinical studies, the clinical trials, and there was a lot of transparency, commitment of both the parties, which really helped in very expedited development of this vaccine. And I think nothing better could have been done as far as a strong public-private partnership is concerned. And also, like ICMR went ahead to validate whether this vaccine works on the evolving variant strains of SARS-CoV-2 also. And at every step, there was huge cooperation from Bharat Biotech and also commitment and partnership. It's a living example. There are other examples like the Serum Institute and ICMR came together to do the bridging studies of Covishield in India. And now we have partnered on Novavax that has also worked exemplary well. And as far as studies on preclinical various vaccine candidates that are there in the market, doing the that are hoping to come in the market rather, the preclinical studies, the toxicity studies. So the way the private and public sector have come together, I think it's phenomenal in this pandemic. I'll stop at this point.
Thank you so much, Dr. Gupta. That is really nice and heartwarming coming from someone like you. I would now quickly go over to the other side and go to Dr. Yadav. Dr. Suresh Yadav, one of the better known faces in this sector across the country, across the world, and for his extremely insightful views. Suresh, I really want you to tell us about the formidable challenges that the private sector faces in the country. We keep talking about wealth creators and wealth generators and paying a lot of what I call lip service. But in actual sense, what is the big bottleneck? Why are we not able to go fast on the PPP mode?
Thank you, Professor Amir and everybody. I think, first of all, thanks for this opportunity to talk to you and the other panelists here. I think you have asked very, easy and difficult questions. Because everything we want yesterday, we don't want to wait for tomorrow.
Correct.
But I think maybe I think we had discussed this before, but I would like to reiterate it that everybody, that is Professor Jagat, Kate, Mr. Mishra, Anuradha Gupta, they have given a very lucid background of what is happening and what is available in the world and what efforts are being taken. But if you go little in the history and see, I think these pandemics are not new.
No.
Pandemics are coming from the beginning of this century. Right from the first century, we have seen pandemics of the plague, bubonic plague, the Antonian plague, the smallpox, the cholera, and all other diseases. In fact, as recently as for last 15, 20 years, we have seen SARS, we have seen MERS, we have seen Ebola, we have seen Nipah, we have seen chikungunya, we have seen H1N1, and now, of course, the corona. But I think in the background, there was always the fear that in our memory, I think the worst pandemic which has happened and which has been faced by the mankind was the 1918 Spanish flu, because that had affected almost about 500 million people, more than 50 million deaths. And since then, I think everybody, all the scientific community was always worried that if something like that happens again, then what? And taking that into the account, WHO had started a GAP program, Global Action Plan, to develop the, I think, battery of manufacturers to be able to make H5N1 vaccine, because they always felt that H5N1 will strike someday, the bird flu will come, and whatever limited experience that we have of bird flu in last 15, 20 years, almost about, I think, 2,800 to 3,000 people affected, where the bird flu was transmitted from poultry to human being, and having almost about 65% mortality. Now you can imagine that if we are scared about Spanish flu with say about 10% mortality, if it increases, what will happen? Fortunately, in case of corona, I think that has not yet gone really more than 2% or 2.35% as on today in the most endemic situation. And that's the reason I said that if we want a solution, we want it yesterday. But unfortunately, it's not going to happen. Exactly what happened in COVID situation, that when this particular disease came in Wuhan, it was designated by WHO as N coronavirus. It's a new coronavirus. It was not seen before, it was seen for the first time. And therefore, if something new comes, we cannot be prepared yesterday. And fortunately, I think the experience which was given by the flu manufacturing, that every year the strains of flu, they change. And the WHO comes out every 6 months giving indication to the manufacturer that what strains they have to use to make a vaccine available. Unfortunately, we don't use that vaccine in the developing world or in the poor countries. It's only used in the Europe, US, and the other developing world, because they have actually seen the devastating effect of normal flu, where the elderly population, it causes mortality to the extent of almost about 35,000 people dying in US and another 35, 40,000 people dying in Europe every year because of the flu. And when you see death, you are feared. And that is precisely what has happened in COVID now. We have seen deaths not only in China, not only in Europe or America, we are seeing it now in India. And therefore, I think all the previous experience which was gathered in making the vaccines was pulled together. And that was one of the reasons why we could make the vaccine in the shortest possible time, which was possible only because of the collaborations with different institutes and organizations, collaboration between the manufacturers, collaboration with the government institutes, collaboration with the regulators, collaboration with different research labs, and willingness to share the knowledge which everybody had. And I think unprecedented thing which has happened this time, almost about 380 different candidate vaccines were being developed by different laboratories all over the world. And fortunately, as on today, almost about 14 are licensed. Of course, everybody is licensed for the emergency use authorization. Nobody has got the regular marketing authorization so far, but I am quite sure that will happen in near future. And one more thing I think you must take into account, that the devastating effect of the Spanish flu was when the total population of the world was below 2 billion. It was just around 1.7 billion at that time. Today, the population of the world is 7.5 billion. We require, from the present study, almost about 2 doses, and we may require additional doses to get the boosters every year in future. And if that happens, that means we will require to produce almost about 15 billion doses per year. Till last year, the total capacity of vaccine manufacturing globally was only about 5.2 billion doses per year. That was mainly because of the requirement of the EPI vaccine, because 90% of the vaccines which are used are in the EPI programs, and only 10% are used in the adolescents and the adults. Whereas this particular vaccine requires to be given to everybody. And pharmaceutical companies have taken more than 50 years to come to that capacity of 5.5 billion doses, which now we are planning to make in 1 year's time. And it's really not going to happen. We will have to make that kind of infrastructure ready, that kind of buildings ready, the equipment ready, and there will have to be the raw material suppliers which is required, including the vials, rubber bands, ampule, the packaging material, the cold chain monitors, everything supplying and being available to that scale, which is not going to be easy. But I must say that by the efforts of all the manufacturers, today almost about 780 million doses have been actually being used. More than billion must have been produced, which must be in the different stages of testing and will be released soon. People are trying to increase that capacity, but it is going to take some time. So I think whenever any government is going to decide how they are going to use that product within their countries or within the state, they must take into account what is the availability of the product, and then go ahead with deciding how they are going to use it in their population. Taking populistic measures that I am going to open it for everybody when I don't have the product is not going to help the common person. I think this is a very serious thing I am saying here, but unless you are going to take this into account, we'll be landing into different problems. And then all kind of accusations like vaccine nationalism, vaccine politicization, vaccine utilization for my country, my state, which of course started by US to start with, but it has spread all over, which has actually created a problem for a COVAX facility. The COVAX facility was created for making equitable distribution of the product to all the countries globally, which has not happened. Fortunately, we have contributed to almost about 65 million doses for the exports, which includes almost about 40 million doses for the COVAX facility. But that's not enough, because globally, as I said, the requirement is huge, and to reach that level, we are going to take some time. I think I will leave it at that.
Very well said, Dr. Jadhav, very well said, plain speak. And if we don't speak simply and plainly and realistically like you did just now, at this point in time, then when are we going to do that? And you know, it is really unfortunate. And I think that one of the things that we have missed out on in this entire debate has been in how we have not been able to curb the tendencies that you talked about. And you know, and have been quick in hurling accusations across the board. I will now get in Dr. Singh, because Dr. Singh, you are in that wonderful space where you people have not just pioneered this whole exercise, but have actually served a template on how a good public-private partnership can be created, not just between the state and the private sector, but also involving civil society, NGOs, academics. It's been a fabulous partnership that all of you have done. Your quick take on how a partnership like yours needs to be replicated and scaled up to ensure that there are regular innovations that happen in private healthcare and in public. Over to you, Dr. Singh.
Yeah, good evening, everyone. Thank you, Dr. Amir, and thank you, organizers, for providing me this opportunity. I will just enlist some of the interventions which have been taken by BIRAC under Department of Biotechnology, Ministry of Science and Technology, since last year when this pandemic knocked on our doors. And since March 2020, we at BIRAC have released specialized calls only to address the challenges thrown at us by this pandemic. And we have put together all our resources, whatever schemes and funding streams were available at BIRAC. So all those were collated together to launch special calls under COVID consortiums and then follow-up calls under COVID consortiums. And I'm sure that all of you must be aware about Mission COVID Suraksha, which was a follow-up call after COVID consortiums. So the basic objective was there to look at the products and strengthening the ecosystem, because that was one thing, that came into light, that our ecosystem for product development, specifically for startups, that needs to be strengthened so that the companies which are just starting up their campaign on the product development, they can get shared facilities at very affordable pricing to get on the track with the product development. So largely under the COVID consortium, we targeted on vaccines, medical devices and diagnostics, and therapeutics. So along with that, shared facilities for immunogenicity lab, animal testing laboratories, and now we have a network of more than 25 clinical trial sites supported by BIRAC to accelerate the COVID-19 vaccine development. And on the vaccine front, we have about 10 different candidates supported at the different stages of development. And today only one more candidate has entered into the phase 3 clinical trial. So we have now 3 candidates which are in the phase 3 trials and other candidates which are in the advanced stage of clinical trial. These are just vaccine candidates. So one more thing that this funding has done, that this has provided the risk coverage for some of the platform technologies which are completely new for this country, nucleic acid technologies, vaccines which are based on nucleic acid. So these fundings are providing the risk coverage for the product developers, and this is giving them essential confidence that they can actually go ahead with these vaccines and see. We still have to see that how these vaccines perform in the clinical trials. We have to see that. But this is definitely giving a boost to the product development pipeline. And talking about the therapeutics, we are very happy to, you must have seen in the news yesterday that Zydus Virafin, this is one of the projects sponsored by BIRAC that has been approved by DCGI yesterday for treatment of the COVID. So that was one of the projects which was funded early in April 2020, and now we are seeing the fruits of this kind of fundings. Very glad to inform you that now the projects which were funded under COVID consortiums, we have like more than 150,000 RT-PCR kits supported under this mission, and more than 50 lakhs nucleic acid extraction kits developed and marketed under these funding schemes of BIRAC. So overall, you see, we are making impacts in all these different domains. But one thing that we are seeing that still, academia and industry, there is still a gap. Government is intervening to bring together the
expertise of academia and industry together. Academia has their own skill set. Industry definitely they have their skill sets for scale up and product commercialization. But still, in our country, I think this gap has to be filled, and I think both industry and academia needs to take a step, and especially towards newer innovations. Our industry maybe take some more proactive steps and more, partnership from academia, because we definitely have the skilled manpower infrastructure, but if the collaborations between industry and academia is set, that will actually can put us on the forefront of newer and innovative technologies like in the vaccine platforms. So this is what I think needs to be done. And we were just thinking to have a portal, a kind of portal, a unified portal where industry can get access to what is available at the academia to offer them, instead of going individually to the academia. So this is what we are actually conceptualizing at BIRAC. This is still at early stage, but we are just working on that to see that how industry can get a snapshot of what academia has to offer them. So this is all from my end right now. We'll
Wonderful,
be happy to
Dr.
answer
Singh.
anything.
Wonderful, Dr. Singh. I feel a sense of, personal accomplishment here, because, when I was at the Gates Foundation, the BIRAC partnership was beginning, and we were very tentative on some of us, I must confess, on how this will grow. And your last lines left me really very pleased, because we, as academics, nothing matters more than the fact that there is a platform where one would be able to then take the next step and work with industry innovation. And thanks to BIRAC, we have this really wonderful working model. And I think over the last 10 years, this has been one of our better Dr. Mohan, you obviously understand why I kept you for the last. At Bharat Biotech, an organization that people like me have been watching very carefully, have been working very carefully, very closely with for nearly 15 years now. But the whole world now watching you very, very, very closely, and marveling at the fact that you have been able to, over time, it's not just during COVID, you have been able to establish such a wonderful relationship with the state. And in a sector like health, there is really no option but to do that. So I would really, all of us would really like to know from you as to what works and what is it that you would like to see to make this ecosystem better, that will allow private sector engagement across vaccines, not just because we are talking about COVID. You have experience with, we were just last week, if you remember, we were listening to your fabulous presentation at the Marichana Reddy Institute, where you were talking about everything that Bharat has done, and it was really wonderful. So really, that discussion that we had over 1.5 hours or so, I would like you to make in the next 5 minutes.
Okay. Thanks, anyway. Thanks to all of you, especially the PGMI, for giving us an opportunity to participate in this meeting. As you rightly said, we shouldn't remember these kind of collaborations or partnerships just because a pandemic has occurred today. And if you take the history or the basic philosophy of our organization, we've been always pro-collaborative approach. And in fact, our collaboration dates back to one of our first vaccines, the rotavirus vaccine. At one point, we count about 20 organizations which are part of this collaborative project across countries. And in fact, we were fortunate that we actually wrote and published a paper called Team Science in Lancet. It talks about the basic philosophy of how to work with partners. And it had some very fundamental science, it had some manufacturing issues, it had some programmatic aspects, and it had the national rollout. So across the entire spectrum of stakeholders, we had shown how these projects can be made to work. And that's something I'm particularly proud of. And the nice thing about the rotavirus vaccine is not only that we took a very deliberate approach of not copying any of the multinationals at any point of time. We were very cognizant of it. We had our own approach, which was in some parts of the world, the thought is complicated, but we had faith in it in saying that if we can do an oral polio vaccine at a minus 20 degrees C, we can do a rotavirus vaccine at minus 20 degrees C. And then we kind of went on. And today we have a product called Rotavac 5D, which is the world's first and the smallest volume vaccine for rotavirus. So rotavirus to me is a very good example how team science can work. This had US collaboration, it had European collaboration, Indian collaboration, of course, under the leadership of Dr. M.K. Ban, who unfortunately passed away fairly, I would say, young age. Otherwise, he was kind of a, I mean, we need to acknowledge not every day was nice and honky-dory. We had our days of arguments, which could be scientific, which could be regulatory related. But I think the good thing is we kind of gelled together and the collaboration continued for almost 15 years. That's the nice thing. So I feel such models can work. We should be actively looking for such collaborations, not today when we have a pandemic, but even assuming that every day is a pandemic in research, not pandemic for public. I mean, you need to be thinking of emergency in research because the timelines are very different in a manufacturing or an organization like ours. And the second example I'll give is a Japanese encephalitis vaccine. We had some trouble with a multinational partner because of some takeovers which happened, not because the collaboration was bad, but then we quickly went across to ICMR, NIV Pune. All that we did was to take the strain, and today we're quite proud that more than 50-60 million doses of India-made Japanese encephalitis vaccine is being supplied to the Ministry of Health and Family Welfare at a very economic price. And there's some very good publications we have come out with, apart from patents, which we could take. And that's been, again, a very wonderful experience of working with ICMR. Now, coming to COVID, clearly, of course, the relationship with ICMR has been, I would say, simply fabulous. What I'm particularly proud is not just that we have maybe supplied about 15 million doses, or the number of millions of doses is not important today. We are supplying to about 18 odd states. But the good thing is that we are talking about having 7 publications, and each of them in some of the best journals in the world, not just in India or in some parts of the world, but each of them, right from the very preclinical product development work to the phase 1, the phase 2, and including the latest work on the new variants. Everything has been published. So that's the kind of, I mean, you can have very high academic standards because there is, I'm sorry to say this, there's some kind of at times a misplaced notion that, if you are part of industry, you may not have great academic done. That's kind of a little, I have my share of arguments with a lot of people, both in Institute of Science, where I was there for long years, and later on in other spheres. But I think both sides need to recognize that you can do good science. Good science doesn't mean that you have to be in either one of the spheres of life. You can be anywhere. That's a nice thing about this kind of a project. Now, so ICMR's collaboration has been great, and we have very good working relation with them. The product is doing quite well, and we have a few other vaccine candidates which we are now working with other partners in the international arena. So I think to sum it up, what really works is I would say, as what Dr. Nivedita Gupta mentioned, transparency is a key, because one should not be doing a kind of a local optimization of one's own requirements. I mean, one should look for a global minima. I mean, if you have to use a mathematical phrase, you should look for global minima in a typical linear programming rather than local minima approach. Then you will be always thinking of what is good for me or what is good for them, and then you will kind of lose out. I mean, of course, there are priorities and issues of an industry which may be different from an academic world, but I think both sides need to accommodate, and that's where I think that the leadership provided by the Director General of ICMR has been fantastic. And that, I mean, the way he kind of literally keeps track of every small issue, that's amazing. I mean, at his level, and he must be doing it with several projects. So I'm quite pleased. So what really works is the faith that each of the partners in the program will deliver, the trust that each of them are not working with one's own objectives to be optimized, and then the proof finally lies in delivery. And that's exactly what we have done in less than 9 months with Covaxin. We got the strain on actually a May 1st. And by the time we had the vaccine rolled out, it was not even 9 months. So we have done it at the same speed, with far less resources than any of the multinationals. In fact, if you track our development program and then compare with either it's an AstraZeneca or whether it is, if you take the time from when they have started and when they have completed their phase 3 clinical trial to ours, it's absolutely almost to the dot. We may be a few weeks either way, but not more. So I think going forward, the lessons are not just shouldn't stop with COVID. Going forward, one should really be actively looking for how can we engage in this kind of a partnership models. And unfortunately, my own view is that such active exploration has not been done, at least in the Indian context. Some of us do this with multinational companies. We do it with Wellcome Trust. We do it with maybe Gates Foundation. But within India, I think that's what I would say COVID has taught us, whether it is DBT or whether it's ICMR. They have now taken, it has triggered exploring good opportunities. Of course, DBT was, and we are engaged in other projects such as the chikungunya vaccine, which has nicely gelled into an international platform with CEPI. So we have a three-way relation between DBT, CEPI, and Bharat Biotech. So there are various examples that you can do, and you can certainly explore this. That's what I would say. Thank you.
Thank you so much, Dr. Mohan. Thank you also for raising the rather important question, and a question that you have been cornered with for so long, which is this whole thing of publication and so on. So thank you for saying it out there so very clearly, and then talking about how in India we have not been able to explore these collaborations that you have had. That you have had some success in working with Wellcome and with the Gates Foundation, but we need a lot more of that. And that is why, as we come to the last bit of our really wonderful session, I would like to go to each one of you, starting with Dr. Gupta, and asking you for your policy recommendation. Dr. Nivedita Gupta, what do you think we should have as active policy to ensure that there is continuous collaboration, there is a very, very robust PPP model that comes into place in healthcare, not just in terms of innovation and invention and development, but also in delivery. Because you are going to be the driver of this. In this sector, the ICMR is going to remain the most important player, being the regulator in a market, as economists say, where there is such asymmetry of information. You are going to be the regulator. So in that context, what do you think is the policy angle that is missing, or what is it that we should add to our policy that will make this collaboration more robust?
What we have been thinking at ICMR of late is that, first of all, our policy decision should be based on our indigenous problems. So there are lots and lots of indigenous problems and infectious diseases that we have been completely missed out. So with this very active collaboration of ICMR with several private partners and private colleagues really has set us straight in thinking that it is very important for us to map our own priorities in terms of we have periodic outbreaks of Nipah virus infection. We have not been able to make monoclonals for Nipah. There are focal outbreaks of Crimean Congo hemorrhagic fever, Kaisan or forest disease. These are very, very typical problems to India, maybe the Indian subcontinent, I should say. So it is time that ICMR and other science and technology ministries take a lead, identify our indigenous problems, and with our very strong private partners, develop solutions to these problems. So I think that's of paramount importance, and that really puts us in a very strong position. As far as diagnostics, therapeutics, and vaccines are concerned, we really need to focus on our indigenous problems and find solutions. Then I could also see there is a lot of strength in the private sector as far as testing is concerned. So there are lots and lots of underserved areas in India where we do not have facilities for testing or detection of infectious diseases. I would say on a basis of a syndromic approach. And in COVID-19, since we have engaged actively with the private partners, we do understand now that it is very important to map these underserved areas and seek the help of our private partners to strengthen the diagnostic capacities there in terms of point of care diagnostics, also strengthening the labs there, and also strengthening the hospital infrastructure. They can also help us in a big way in training, data mining capacity. So I think there's lots and lots of potential there, which needs to be tapped. So the government can map out the areas, point out the areas where such capacities need to be strengthened, and then loop in the private partners, and with very effective engagements, give local solutions for local problems. So that is going to be the approach of ICMR as far as work on infectious diseases is concerned. I hope I was able to answer your question.
Wonderful, wonderful. Thank you for saying this, because we've been looking for such a statement coming from you, where we will have the private sector use its obvious capacities and obvious capabilities in reaching out, in developing data, in looking at mapping epidemics, and using their strength in testing. Because last year we were all very perplexed when testing was restricted to the government sector, and we did not see the private sector or the community-based organizations come in, and that led to very slow offtake of testing in the beginning. So very, very nice of you to have said that so clearly, and I'm sure that if it's in your leadership, then we will see this policy change coming in very soon. Dr. Singh, you face these challenges. So what is your policy recommendation? Where do you feel challenges? Dr. Miraj Singh, what challenges do you face in getting in this robust private sector to work with you?
Well, I totally agree with what Dr. Gupta has stated. The challenges we have faced from, there are actually no challenges as such in accepting the problems from private sectors. I mean, private sector is more than willing to go to come up and take up the challenges which have been identified by the governments, and different calls are invited in those particular sectors. So there is very good response from private sector. But as I said it earlier, the real problem what we have faced is there is lack of collaboration. There are lots of individual efforts from private sectors, but they are not coming as a collaboration. Like there is no consortium to address a problem which is actually being forward. So there is limited capacity with everyone, and an individual effort from a single entity is never sufficient to solve a larger problem. So what we have encouraged in our RFPs also, that people should form collaborations which actually work on the ground. They should identify each other's strengths in this area, and then those compatibility match should come up when they are proposing to start work on a problem. So this is something that cannot be forced, but applicants or private sectors or academia who are actually willing to work on a problem, they should identify each other's strengths and form a collaboration and then start to work on a problem. Another thing is that private sectors should actually invest in academia. That is one thing where I think private sectors, especially the bigger companies, they can start investing. I mean, we have seen this model in Europe and America, that they can give these problems to academia, who can come with very, novel solutions to the problems. One thing that we have seen is associated raw materials with any product. With any finished product, not all the raw materials are manufactured in one geography. And that has actually affected the affordability of any product. So in our recent efforts, we have been trying to identify that what are the raw materials and associated industries that can be brought together to kickstart the manufacturing of those raw materials, like for diagnostic kits, what sort of proteins can be, or enzymes can be, or protein reagents can be manufactured in India to accelerate that section. So we need that ingenuity from private sector and that collaborative effort between private and academia. And I think that can actually strengthen the product pipeline in India. So that's my point on that.
Wonderful, Dr. Singh. It's a very interesting point that you make, because let me admit that most of us have been arguing that it is the state that should fund universities and academics. And you are making a great point where you're saying it is the private sector that should fund universities and research labs. Because, if you look at the US and Europe and whatever, you see the enormous amount of state funding that goes into most of the universities that work on public health and infectious diseases. Our budgets for our universities are, to make an understatement, meager. And therefore, your point on how we incentivize the private sector to fill that gap, as we now call it, and fund our large research labs is an interesting idea. And I think that if we can convert it into policy where we channelize some of the large corporate funding that is coming out into these activities, it will have to be very ingenious policy that will make private sector invest in research, and we should be able to develop some good policy instruments to incentivize that. Thank you for making that point. Let me get to Dr. Mohan. Dr. Mohan, you have worked with academics, you have worked with the government, you work with foreign collaborators. What policy recommendation would you suggest that is the challenge in working with such networks in India?
See, my personal view here is that it's not so much about policy, but I think the atmosphere. Policies can only it'll be like a constitution which is written out. It should be more than a policy. These are all nice documents to read. There'll be all kinds of nice documents which then get filed. The willingness to brainstorm, let's say, what are the 10 most, if you take neglected diseases, let's say, or communicable diseases, you take one segment of research. There are so many things one can do in the world, so you need to stay focused. At least each one will have their own priorities. Our priority is very clearly neglected diseases for the developing world. We are pretty focused on that. We don't go beyond that kind of topic, because whatever we do should revolve around that. Then once you say that this is the neglected disease, one needs to have to evolve a policy, or more than a policy, a framework of collaboration. Who has what strengths? What kind? I mean, a simple thing which we often lack. Everybody would agree, and this is not a criticism against any one specific segment of our system, but you talk about a disease and then you look for epidemiological data. Most of the time, epidemiology is kind of a little lacking. I know that we have a National Institute of Epidemiology, so people shouldn't misunderstand that. But when you start really looking at data and say, what kind of a good background data exists, how do you define epidemiology for any specific disease, and then go on to say that doing large-scale efficacy trials, you need a huge amount. It's not just about money. You need a lot of brain power. You need a lot of in-depth thinking. And India as a country has not done, again, maybe I'm kind of being a little critical, we haven't done many efficacy trials. The one efficacy trial we did long ago was on rotavirus, but we had a significant amount of international. It's not so much about the money again. I mean, money is only one part in my story. Money is essential, but money is only one part. What is important is what kind of a skill sets we have, what kind of an expertise we have, what kind of thinking we can have, and then bring the right kind of people to take a specific problem and say, this is the problem we're going to work on. And that kind of a requirement, we often, again, sorry to say this, we often might find a collaborator somewhere else in the world. See, that's something, with some difficulty, we did a kind of program for typhoid in Navi Mumbai for our typhoid conjugate vaccine. But the first time we went to Oxford to do a human challenge model. And only because we did the human challenge model on typhoid conjugate, because there were no efficacy data, that's how, for the first time, Bharat became a company to have world's first typhoid conjugate vaccine. We have actually outpaced, whether it's a Sanofi or a GSK or a Novartis. We also were manufacturing and marketing typhoid vaccines. It's not that they were not interested in typhoid vaccines. It is a segment GSK or Novartis was very much interested. But this collaboration with Oxford really changed the whole game. And now we have several other human challenge models. So capacity building in a right manner is, to me, an important issue as much as a policy. Policies are only guidance documents, frameworks, capacity building, taking a specific problem and brainstorm and bringing together. I haven't seen that kind of a thing happening often. Maybe it might happen elsewhere, but what I'm saying is a proactive approach in these areas, whether it's a communicable disease, non-communicable disease, it doesn't matter. We'll stick to health. I have had some prior experience in other areas of science, but those I'm leaving it out for now. But if you talk of health, that's important. You take space as an example, space science, space research. It's so self-contained in the institutions of the Indian Space Research Organization. They're able to do a lot of it on their own. There are a few academic institutions which get affiliated, but you are not able to do that in health. So I think somebody like you actually should be looking at what has worked in other areas of science or technology and how do you extrapolate it to health as an example. There could be learnings from how other segments are handling these issues. So, I mean, I can go on, but I think I should stop somewhere.
Wonderful, wonderful. Thank you so much. And, for building that capacity issue, we have all faced it. Ask us, and Raj is on this call, on this seminar, at the Gates Foundation, we really tried hard to get the kind of capacity.
Yes, yes.
We always had to depend on some foreign university and some foreign institution, which is expensive, and as Dr. Gupta said, is not indigenous. So it takes that much more time to get accustomed. So I will come to Dr. Suresh Yadav, and I've kept him for the last deliberately. Sir, because you're getting the last word, and we are ending this program with you over the next 3 or 4 minutes, your straight policy recommendation. What is it that we want? 1, 2, 3, please.
I think everybody talks about the PPP, right? The public-private partnership. And no doubt, I think there are dozens of examples that it has really worked and has given out excellent outcome in terms of new products, new technologies, new collaborations, and all that. But when we talk about particularly the vaccines or the biological field, what we require is tremendous amount of support from the regulators. Unfortunately, what has happened is the regulations are different in different parts of the world. So once the product is ready, and then when you want to go for registration, you have to face different kind of expectations from different governments. I'm just giving you an example that even if there is one product and you have to go and register it in, say, about 100 countries, you have to make those different expectations of individual state governments or governments, how they want that application to be submitted. There is no harmonization there. So what I feel is that if there could be some sort of a effort to make a harmonization for registration, harmonization for regulatory requirements within the country. I must thank, I think, our regulators that for the COVID, they had bent backwards to help the industry. We have got examples that we have made application today, and within 24 hours, we have got the permission, which was not happening in the past. And I feel that this kind of experience should continue for all other products which will be coming in future, and it should not be restricted only for the COVID experience. Because COVID was a very different situation, it was a pandemic situation. But taking cue from what is happening in Europe, what is happening in USA, what are their regulations, our regulatory people should also come forward and be ready to make changes so that it will help the industry exactly on the same lines as it helps outside. If I have to do a phase 1 clinical trial in normal circumstances, it will take anything between 4 to 6 months to 8 years, even up to a year. I have got examples, the things were delayed by 1.5 to 2 years. Whereas if I go to US, I go to Australia, I go to Bangladesh, within 1 month, my phase 1 clinical trial starts. So we need that kind of proactiveness from our regulators, and if required, make necessary changes in the legislation to get those things changed and implemented within the country. Similarly, I think we need to have proper changes in our analytical requirements. There are some archaic, I think, expectation in our regulations which needs to be changed. And I am quite sure that with these new changes which we are taking place for COVID vaccine, they will also be changed for the other products. We have got excellent experience from the regulators, not now, but even in the past, even for the H1N1, when we wanted to do our meningitis product or pneumococcal product or the rotavirus product, where they had allowed us to do and make submissions simultaneously with our regulator as well as with WHO to save the time. So that kind of situation should continue so that in future, we will be able to do and make the product available in the shortest possible time. There are certain regulations, even with the Department of Biotechnology. I think this is for Dr. Miraj Singh. The requirement of our RCGM, it should go exactly on the lines of what is the expectation and what is the current practice in EU or in US. we should not have something very different and very lengthy procedures so that things are delayed. That is the experience of the industry all over, which I think you should take it back to the department and try to see that these regulations are coming exactly on the international lines so that the life of the Indian manufacturer becomes much easier. I will stop at that.
Wonderful, Dr. Jadhav, wonderful. You know, it's so important for us to have integrated policies where the private sector is not caught between different sets of regulations across the world and faces great transaction charges. This crisis has given us the opportunity, and we must thank people like Dr. Gupta at ICMR and so on to ensure that things could be circumvented and that we could work at such breakneck speed like the Serum Institute and Bharat Biotech have. And therefore it gives us a great optimism that as we fight various diseases, and this is not going to be the last, we will do it with as much alacrity and with as little speed breakers as we can. I must thank all of you from the bottom of my heart. It's been a wonderful discussion. You've all been so very disciplined, so honest, so straightforward, so clear in your thinking. And I really wish that this is the kind of ecosystem that we have for everything that we do in the country. It will really allow us to tackle problems with the kind of focus that Dr. Mohan talked about and the kind of prioritization that he underlined. So thank you very much, Suresh Sir. It's always so wonderful to talk to you. It's absolutely wonderful again. Dr. Gupta, Dr. Singh, Dr. Mohan, thank you so much for being here. Adarsh, thanks. It's worked wonderfully well. Thanks for all the support. So over to you.
Thank you, sir.
Thank you.
Thank you very much. Thank you.
So before we close the session, we have a couple of questions. We need to take that. So the first question is for Dr. Kosin, if he is here. Sir? Yes, he is still here. So, sir, the question is that given Indonesia's geography of many islands, what effort does the country take to ensure they reach remote or difficult to access areas, particularly as COVID-19 has impacted geography rate, the coverage rate? Dr. Kosin, if you can. Okay, by the time sir comes back to us, we have another question. Does the vaccine stop transmission of virus? How much is it possible that a vaccinated person being symptomatic or asymptomatic may prove as a carrier of COVID-19? So Dr. Kosin is here. I think first we can go to him. Dr. Kosin, please unmute yourself. Dr. Kosin, we are unable to hear from you. Thank you. The question says that given Indonesia's geography of many islands, what efforts does the country take to ensure they reach remote or difficult to access areas, particularly as COVID-19 has impacted coverage rates? Would you put some light on that, sir?
Yeah, actually, we have the infrastructure for the national immunization program that used to cover those islands. We have about 3,000 inhabited islands. So we have about 34 provinces and 514 district and city. So that's already established for NIP. So doing the supply of the PCV, it will be just another additional immunization. So not a problem.
Okay, sir. Thank you, sir. So another question is, does the vaccine stops transmission of virus? How much is it possible that a vaccinated person being symptomatic or asymptomatic may prove as a carrier of COVID-19? So we have esteemed panel, So, Jagat sir, Mohan sir, Nivedita ma'am, if you can answer, any of you can put some lights on that.
So I'll just start with a brief understanding that I have, and then I'll leave it to Dr. Jadhav and Dr. Mohan to supplement. So the current vaccines of COVID-19, they have been designed and the trials have been conducted in a way that we have evidence that they would prevent severe disease and deaths. We do not have data enough now to say that they will stop transmission. And even if you look at the immunization programs, particularly if you look across the world, the immunization programs currently for COVID-19 are not designed to stop transmission, except for a few countries like UAE and all, where they are immunizing the complete population. So if you look at the immunization program in India, we first targeted people who were above 60 years of age and healthcare workers. So the reason why we targeted people above 60 years of age was that we wanted to prevent severe disease and deaths, because a huge number of people there are comorbid and there are chances that they would land up in severe disease. Second was healthcare workers. Why did we target them? Because healthcare workers, if they are positive, they can actually lead to super spreader events. So these two groups were targeted. And in turn, when they would be super spreader events, there are a lot of comorbid and sick individuals in the hospital, which would again lead into severe infections and deaths. So the program was targeted in a way only to prevent severity, not the transmission. And that's the case that we saw in US and several other countries which target reduction in severity. However, right now, I do not think that we have data enough to say that these vaccines would prevent transmission, but definitely we hope to see that data in future. I leave it at this point, and I would request my learned colleagues to add more or correct me if I'm wrong. Thank you.
Mohan sir, if you can comment.
Yeah, I think no, the simple answer is quite right, that these current vaccines do not really prevent transmission. It could be a kind of a fallout, but they are not. This is a specific reason today we have a nasal vaccine which is in clinical trial. We're almost completing our phase 1. And the nasal vaccines are specifically designed to take care of transmission, because in the case of nasal vaccines, as we all know, it's through the nostrils and the mucosa, and that's where your virus really starts off its journey. So the nasal vaccines, it's strongly believed that are the answer for preventing transmission. The rest of the advantages of the current vaccines, I think Dr. Nivedita has already explained. To keep the answer brief, the way to go would be to nasal vaccines.
Right, sir. Thank you. Dr. Jadhav, if you want.
I think Dr. Nivedita and Dr. Krishna Mohan has answered it correctly. So to sum up the question is that the current vaccines which are available do not stop the transmission. A vaccinated person can get the infection again. He may not show the symptoms, but he could still be a carrier and spread the disease. So therefore, the minimum precautions that we are continuing to take now need to be taken even in the future.
Right, sir. Thank you. Thank you so much, sir. So thank you for a very fruitful discussion. And unfortunately, we couldn't get Dr. Mathuram's presence over here. So he has sent her thoughts via recording. So could I please request the backend team to just play Dr. Mathuram Santosham's recording? The backend team, can you hear us? Just play the recording.
Yes, sir, we are playing.
Thank
My
you.
name is Mathu Santosham. I was born in Vellore in South India and studied in Jitmur, Pondicherry. I have now been at Johns Hopkins University for the last 4 decades, but also had the great privilege of working closely with many of the luminaries who will be speaking today. I don't think I need to tell you all that vaccines are one of the most powerful and successful tools in public health. And this has been recognized by the World Health Organizations. We now have vaccines against 20 life-threatening diseases. And we can now prevent 2 to 3 million deaths every year, which is actually what's been happening. When I started out my career, the only thing we had at that time was BCG and DPT. We have come a long way. The value of vaccines is apparent now more than ever before, as the world is tackling this dreadful pandemic of COVID-19. The World Health Assembly, with the support of countries and partners, has endorsed a new global vision and strategy called the Immunization Agenda 2030. You might hear people refer to it as IA 2030. IA 2030 is a framework to inspire, align, and guide regional and global stakeholders in realizing immunization goals in the next decade. Its vision is a world where everyone, whether rich or poor, everywhere, at every age, fully benefits from vaccines to improve health and well-being. Its goals include ensuring sustainable immunization programs as an essential part of national primary health care strategies, building, sustaining, and strong political and financial commitments to immunization. This part is particularly extremely important because we cannot really move forward without strong political and financial commitments. Also reaching zero-dose children and extending coverage to all people. It staggers my mind to think that at this day and age, there are children living around the world who have received no doses of vaccination or immunization of any kind. This is totally unacceptable. We have to change that. And we also need to be prepared for any new epidemics that may come by, just like the COVID-19. Of course, we need to aggressively stamp out COVID-19. But as a society in the world, we cannot let any other organism find us unprepared. And we need to build trust in vaccines. In 2019, the WHO declared vaccine hesitancy as one of the top 10 threats to global health. And you know that social media has played a huge role in this. This is a huge task, and we all need to work together to handle this issue. The goals that have been set out by IA 2030 by the agenda aims to save over 50 million lives in the next decade. By maintaining progress made in immunization and building upon past successes, while overcoming impediments caused by the current COVID-19 pandemic. As you all know, the current pandemic has been a huge detriment, not only to vaccination, but to healthcare in general. I think it's important for us to address the national and regional priorities. Handling the current COVID surge is what we must do. There is no choice. Fortunately, the virus is spreading faster than ever before in India. The government reported a staggering 270,000 new infections nationally last weekend. And I understand it's going up even further. But I would also like to point out, India has been a shining example in the world. While tackling its huge needs in the country, India has actually produced and exported vaccines to other countries globally. And those countries have benefited greatly from India's generosity. As the world's third largest manufacturer in pharmaceuticals, India is well poised to scale up supply for its own populations. India has been exemplary in the pace at which it has been immunizing its populations. On many days, it has reached over 2 million doses per day. This is probably the fastest rollout in comparison to many other countries. We now have vaccinated in India, provided over 97 million doses to the population. Keeping up with this remarkable pace will be crucial if India is to reach its goal of vaccinating over 300 million people by this fall. But in spite of this progress, we really need to accelerate the immunization even more. That is a huge challenge. There are supply constraints. We need to make sure that everyone who got the first dose gets the second dose as well. There are huge cold chain challenges. Local governments have stepped up to strengthen the existing delivery infrastructure and have greatly strengthened their ability to ensure that COVID-19 vaccines are safe during transport and storage and during delivery. Training of the staff is also a huge challenge, but India has certainly done a great job with that. Vaccine hesitancy, as I mentioned, is a huge challenge. We need to listen to the concerns of the communities, the health workers, and others who don't necessarily think the same way that we do. And we need to be responsive to these questions and not dismiss those questions. That's the only way we can improve trust and avoid escalating hesitancy. COVID-19 cases, as I mentioned before, are soaring in India, despite the country's incredible scaling up of vaccine efforts. Part of this is because many variants have now invaded many countries. The battle against COVID-19 is a race between vaccine coverage and infections. In order to stop the pandemic, we need to immunize as many individuals as possible so that the organism does not have the opportunity to infect anyone. If we reach immunization coverage of 70 to 80%, we can achieve herd immunity and protect even unimmunized individuals. This is a monumental task. However, India is very capable to rise to this challenge. Thank you very much.
Thank you, sir, for the beautiful insight you have given. So we have come to the end of the day. I like to invite Shohini Paul, Senior Manager, for rounding up and briefing upon the takeaways from the day. Shohini, if you can take over.
Thank you, Dr. Adarsh. Am I audible?
Yes, you are.
So in the interest of time, I think I'm going to cut short the rounding up and key takeaways a little bit. Dr. Adarsh, you can cover it in tomorrow's recap session. So just before we end, I wanted to thank all of you today for joining us to make day one of this virtual symposium such a success. We've heard some of our most eminent global and national experts on immunization come together in the symposium, and we've heard a series of very insightful and fascinating discussions today. So I just want to take a moment to thank all the panelists and speakers who spared time during this very difficult time to provide their valuable insights today. Dr. Amarjeet Singh, Dr. Jagat, Dr. Kate O'Brien, Mr. C.K. Mishra, Dr. Raj Shankar Ghosh, Dr. Anuradha Gupta, Dr. Mathuram Santosham, Dr. Pradeep Haldar, Mr. Neeraj Jain, Dr. Kosan, Dr. Suresh Jadhav, Dr. V.K. Mohan, Dr. Miraj Singh, Dr. Nivedita Gupta, Dr. Amirullah Khan, and of course, everybody at the PGIMER team, with a special thanks to Dr. Madhu and Dr. Adarsh for bringing everyone together for this wonderful day one of the symposium. Tomorrow, we have a series of very exciting sessions planned that focuses on a very critical and topical issue that's building public trust in vaccines and how we can tackle misinformation and vaccine hesitancy. So we have some amazing sessions lined up for you tomorrow with speakers like Dr. Tavneet Thakkar, Dr. Heidi Larson, Dr. Jacob John, and many others. So we hope to see you tomorrow again. And thank you so much for sparing the time and joining today. Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you.
It's a humble request to everybody, to all the participants, to provide us the feedback using that feedback widget in the lobby. That will be really helpful. Thank you, and surely